everyone. Lovely to see so many of you here on time and ready for a day full of energy. The energy in the room has been lovely, coming in and out all morning, picking up on that. For some of you, a bit of a nervous energy, I'm sure, and for others, there's some excitement there. So good morning. Hello, my name is Dan Shaw. I work with the District Midwifery team, and I'm really excited to have you all here today. I will be your MC across the day, so you'll get to know me really well and be sick of hearing my voice by the end of the day. I'm welcoming all of you into the room, but also to our online attendees. We have quite a number of people joining us virtually today, which is really exciting, and the wonderful Tat will be looking after our online attendees. So a little bit of housekeeping before we get started. Bathrooms are just outside the door you entered through to come in this morning into the main part of the building. There are another set of bathrooms up on level 1 in the same layout as they are down here if you do need them. In the event of a fire, we are going to be very calm, cool and collected, and we will follow our wonderful Katrina here. If you could give us a wave, who will take us out through the main door, up the hill, over to the hydrotherapy pool where we will congregate. That's in the unlikely event of an emergency. We know you have to take calls across today and be on your devices, so we just ask that if you do need to take those, you step outside of the auditorium. And if you're on devices in the room, just ensure those are set to quiet, just out of respect for our presenters. I would like to ask our district nursing midwifery team just to stand up. They'll be your key contacts across the day if you need any help. So stand up and give a wave. They are your go-to people for today. If you do have any requirements, please seek out one of the team. They'd be more than happy to assist. You'll notice in the function room next door, we have the posters displayed digitally across 4 screens. So not every poster is on every screen, otherwise you'd be there for quite a while. So make sure you get around to each screen and have a look at the posters, and you'll be able to vote on those across the day. So we ask you vote once, and on that vote you vote for your top 2 posters. They'll be awarded at the end of today. We will have morning tea and lunch in the function room, and make sure you get around to our forum supporters who have joined us today in the room. So without any further ado, I'd like to hand over to Kate Hackett, our District Director of Nursing Midwifery Services, to welcome us all and acknowledge country.
Sorry. Good morning, everyone. I'd like to start by acknowledging the Bidjigal people of the Eora Nation, of whose lands we are hosting the forum today. I'd also like to acknowledge Aboriginal and Torres Strait Islander people of the Dharawal, Gadigal, Wangal and Wigal lands that all our sites and facilities operate on. We pay our respect to ancestors and elders past and present. Welcome to those joining the forum virtually. Today, I'd also like to acknowledge the many lands on which you are joining us from today. It is with great pleasure and excitement that I extend a warm welcome to you all for attending the inaugural South Eastern Sydney Local Health District Nursing and Midwifery Research and Innovation Forum for 2025. It's a fantastic time of year for us to celebrate nursing and midwifery, obviously in between International Day of the Midwife and International Nurses Day. This landmark event marks a significant milestone in our district's commitment to advancing nursing and midwifery through research and innovation. Today we gather to acknowledge and celebrate the remarkable efforts and achievements of all of our dedicated nurses and midwives. Your relentless pursuit in research and innovation has not only enhanced the quality and safety of patient care, but has also profoundly improved the human experience within our healthcare system. This forum serves as a unique platform for you to present your pioneering work and to share insights on how it aligns with South East Sydney Local Health District Nursing and Midwifery, our strategy for transforming person-centred cultures 2024 to 2029. There's copies of the strategy, and also one of our presentations this morning is from Dan and Susie from the Nursing Midwifery Directorate, giving an overview of the strategy. It's an opportunity to showcase the transformative impact of your initiatives and to inspire continuing progress in fostering person-centred cultures across our district. We're here to celebrate your successes, to learn from each other and to collectively envisage a future where research and innovation are integral to our practice. Your contributions are vital to the ongoing evolution of nursing and midwifery, and we are immensely grateful for your dedication and your hard work. As we embark on this journey together, I encourage you to engage actively, share your experiences, and take full advantage of the knowledge and opportunities presented here today. Let us continue to drive excellence and innovation in our field, ensuring that our patients receive the highest standard of care. Thank you for your unwavering commitment to nursing midwifery. I look forward to a day filled with insightful discussions, inspiring presentations, and the celebration of our collective achievements. Welcome to the South Eastern Sydney Local Health District Nursing Midwifery Research and Innovation Forum for 2025. I'd now like to hand back to Dan.
Thank you so much, Kate, for welcoming us all this morning. Wonderful to hear those words from you. I'd now like to hand over to our Chief Executive, Mr. Tobi Wilson, who is here to formally open today's forum. Welcome.
Thanks, Dan. Thanks, everyone. And can I also start by acknowledging the traditional custodians of the lands we gather, the Gadigal people. It's an honour to be here today to welcome you to this event, the SESLHD Nursing and Midwifery Research and Innovation Forum for 2025. Today we are excited to come together to celebrate the work that's been going on by our nurses and midwives across our district. Groundbreaking work and the commitment that these groups have in delivering on projects that are targeted around delivering our strategy and expanding the knowledge base for nurses and midwives. This forum highlights the exceptional research and innovation practice that our nurses and midwives are leading across our district. It's a day that recognises the strides that we have made in enhancing the quality and safety of patient care, improving the human experience and nurturing patient-centred cultures across all of our healthcare system. And nurses and midwives are at the forefront of these advancements, and their contributions are pivotal to the ongoing transformation of our services. This event provides a unique platform for us to share, ensuring that we continue to make strides around how we deliver our nursing and midwifery strategy, our strategy Transform Person-Centred Cultures 2024 to 2029. So we're all here today to celebrate your achievements, to learn from your experiences, and to inspire one another to continue to push boundaries on what is possible for nursing and midwifery. Your commitment to excellence and innovation is the driving force behind our success, and for that we are profoundly grateful. I encourage you to engage fully with the sessions today, to share your insights, to embrace the opportunity for collaboration, and to learn that from what this forum has to offer. We know that if we have a workforce, a nursing and midwifery workforce that's embedded that's focused on research and innovation, it will be integral for our practice development, and it will ensure that our services for our patients receive the highest care. Thank you for your dedication to being part of this exciting day. I look forward to a day that's filled with inspiring presentations, meaningful discussions, and a celebration of our collective achievements. It's my honour to open today's session. Thank you.
Wonderful. Thank you so much, Tobi, and what a privilege to have you here this morning to formally open our forum. So next up we have our esteemed colleague and friend joining us today. We are absolutely delighted and over the moon to have Professor Brendan McCormack here with us today. Many of you in the room will know Brendan and his incredible work over many decades in supporting person-centred practice and cultures. So Brendan, I would like to do a formal introduction, so bear with me. Brendan McCormack is Head of School and Dean at the Susan Wakeful School of Nursing and Midwifery, including Sydney Nursing School, the Faculty of Medicine and Health at the University of Sydney. He is an academic chair of the CARE program at Sydney Policy Lab, University of Sydney. Brendan's research focuses on person-centred healthcare with a particular focus on the development of person-centred cultures, practices and processes. He is specialised as a clinical nurse in gerontology and dementia care. Brendan is a fellow of the European Academy of Nursing Science, the Royal College of Nursing UK, the Royal College of Surgeons in Ireland, and the American Academy of Nursing. He has been awarded the Sigma International Nurse Researcher Hall of Fame. He is also a member of the Academia Europaea, I hope I got that correct, prestigious European Scientific Academy. He has over 700 publications reflecting these research areas, including 310 peer-reviewed publications in international journals and 14 books. His age index is 51 and has been featured in the Wiley Publishers Inspiring Minds short film series. There's a link in the virtual program for you to be able to view that. In recognition of his extensive contributions to person-centred healthcare, in 2023 he was awarded an honorary doctorate from the University of Maribor, Slovenia, in recognition of him being the first nursing professor in Slovenia and for his service to nursing and healthcare. In September 2024, Brendan was selected to join the Lancet Global Commission on People-Centred Healthcare for Universal Health Coverage, hosted by Harvard University, and made an affiliate academic at Harvard Medical School Centre for Primary Care. It's my great pleasure to welcome Brendan to the stage to share his keynote presentation with us today.
Good morning. Can you hear me okay?
Yeah.
Thank you so much, Dan. Thank you, Tobi, for launching this event, which is fantastic to see it happening, and to Kate and the team for making this happen. It's really fantastic to see nursing and midwifery research being hosted like this and actually really put forward, and it's fantastic. I was looking at the programme and just thinking, well, there are so many familiar names in that programme, which means I've been around for quite a while. And also know quite a lot of people here in the room, which is really fantastic. So congratulations on making this happen. I was asked to talk this morning about kind of weave together my own kind of journey as a researcher in this space, alongside some of the critical issues we're addressing around nursing research. And what's kind of happening in that space and some of the challenges we have. And then to speak a little bit about some of the work I'm currently doing, what's occupying my interest at this moment in time, which is, kind of extensive, but trying to hold on to it. That's the most important part. So again, delighted to be here, and I hope that those of you who've heard me speak ad nauseum, that you're not too bored by the time I finish it, but there's also some kind of nuggets that will help drive forward nursing and midwifery research here in South East Sydney, which is really fantastic. So, I wanted to I labelled it a global perspective on building research culture and capacity in a clinical setting. And I don't know if any of you have read Charlie Mackessy's book on the boy, the mole, the fox and the horse. If you haven't, you really should. But there's a great quote, it's full of great quotes. And one of them is, "We have such a long way to go," said the boy, "but yes, but look how we've come," said the horse. And I think that is a really powerful message that we need to hang on to in relation to nursing midwifery research here in Australia and globally, which I'm going to connect with, because there's always more to do, and there are always challenges, and there are always problems, and there are always issues. But actually, we have an incredible, vibrant community, and these kind of communities maybe even more so, and are doing some amazing work in capacity, capability building for the future as well. So it's that kind of picture I want to try and hang on to. Nice. Okay. So just a little bit about I guess start with me, and you know person-centered work, start with self first and then build out, and that's where I'm going to start today. And I guess the real message in this story is that I've been around a long time, and that's when I look at it. So this is my 45th year as a nurse, and when you think about that, then a lot happens in 45 years, I guess. And I seem to have been part of that movement throughout those 40 years. And I think what's interesting is about the way that nursing has responded to those kind of changes, because they have been quite profound as we've gone along the way. Some of them for good and some of them not so good. And I think I'll say something about that where we're at currently in that regard. But you can see that there has been this kind of 10-year cycle of shifts in healthcare and in nursing midwifery. It's that cyclical nature of healthcare and of nursing midwifery practice that we have to really consciously and continuously be paying attention to. There is no place for kind of just sitting on our laurels and thinking that what we have is now how it is, because actually we know that these kind of 10-year cycles continuously happen, and they bring about some profound changes in the way that we happen, the way that we work and don't work. And this timeline here just reflects this kind of trajectory of change that I've been part of over that period of time, and which we have had to really respond, I think, quite rapidly at times in the way that we do research and development, quality improvement, and education. And all of those things need to weave together if we are going to have to be successful. As Dan did say, though, I mean, when I started out as a psychiatric nurse in 1980, I had no intention of ever being standing somewhere like this, doing this right now, not in a trillion years. In fact, as many of you know, all I ever wanted to be and still want to be is a chef. That was the only ambition I ever had. I completely fell into nursing by accident. But it became kind of the total passion for lots of reasons that I could bore you to death with for another very long time. But in that period of time, as well as kind of going through those changes, I think I've just grown and developed and changed quite a lot in that period of time. And the Lancet Commission I'll come back to later, because it's really quite an incredible experience at the moment. Again, never thought back then in that psychiatric institution in the middle of Ireland that that's where I'd end up. But also then this year I was also awarded the Paul Tierney Prize by International College of Person-Centered Medicine for my contribution to person-centered medicine, which I never thought I'd really contributed to, but actually they decided that had quite a profound impact on them. Which was, again, interesting in terms of breaking down barriers and breaking down interprofessional principles and practices that we need to engage in. But where it began for me, and I always put this book off as the beginning, but actually began much earlier than this for me. When I did my nursing degree, after I'd done the usual rounds of hospital-based trainings, I really got interested in research, mainly because of a philosopher, and that has kind of been the continuous story for me. I come to research through philosophy more than kind of clinical questions per se. And I think it's the combination of those things that really works. And then eventually ended up in Oxford doing my doctorate in philosophy. And out of it came this book. This was actually my PhD thesis, which was called Negotiating Partnerships with Older People. And I was very fortunate to be approached by a publisher to publish my thesis in its full, with some of the methodological stuff taken out of it, and then made it look more like a story that people want to read rather than the turgid thing that it really is. So that actually was such a platform for moving forward, because what was in that, and that was in 1997, was this framework. And given the work that I know is happening in SESLHD around the person-centered strategy and the person-centered practice framework, then you can probably see strong familiarities with this original framework and the one that you currently have based your nursing midwifery strategy on. And it was the authentic consciousness framework, very much focused on older people and people living with dementia, and how do we engage in conscious caring and be authentic carers in that process. Very much built on the work of Tom Kitwood, who was a huge critic of mine at the time, actually, because he believed that I got it philosophically wrong by talking about consciousness. But we had a great discussion about that, and that was all fine. But actually, it was that whole engagement in this work that really sparked everything became sense. But it had started prior to my PhD, when I was running a nursing development unit in Oxford, and we were really experimenting experimenting with how nursing could be different from how it was. But of course, you don't do any of this alone. And I think it's always very humbling when you look at who have those people been who have been significant in our lives in terms of our work. And no researcher does this alone. It's not a lone person's job. And there are hundreds of really important people in my life. Interestingly, I was reflecting about this last week, all of them very powerful women. Women who have really made a huge difference in the lives of other people and in everyone else's life. Tanya McCants, you know very well. We were here last year, I think it was, launching the strategy together. And I know she's still working with you. And Kitchen was here very recently, and I know worked very closely with Susie and Mary and many others here. And my very dear friend, colleague, and pseudo sister, Professor Jan Dewing, who very sadly died just almost three years ago, but with whom I carry with me every day of my career, and is never far away from me as a person. But these have been three kind of really important people in terms of shaping thinking, shaping the way I've grown, the way I've developed, who I am as a person. And I think I wanted to labour this because I think it's so important for all of us to know who those people are in our lives, and we all need them. It doesn't matter how senior we are, how developed we are, how expert we are, we need these people in our lives to really shape our thinking and to kind of think outside of the box that we get stuck in quite a lot. Last night at Sydney, we launched the next iteration of Sigma Omega Xi Omicron chapter at large, and Sydney has just joined with Newcastle in that large group now. And we were talking about this, about knowing our tribe and knowing how we could step out of our tribe to connect with others to form a critical community. I think that is a really important message I want to give you up front in terms of growing research capacity, is know who your tribe is, hang on to them for your life, and then connect with other tribes. And there we go. So on the back of all of that came the person-centered nursing and the person-centered practice framework, which I think if you work in this health district, then you're probably pretty familiar with it. I'm not going to say too much about it, but it has been the platform really upon which all of the work that I've done ever since has been built, and has been incredibly impactful in some regards. I wouldn't say completely. One of the joys of it has been the number of PhD graduates who've come through this process, of 58 of them, all of whom have kind of really kind of stretched boundaries around different components of this work and really challenged it. So much of the work that I kind of normalised now as part of my own research, as part of my own work, has come through those PhD students. Quite diverse, right across all kinds of systems. Again, Tanya, Jan and I captured those PhD stories in this book that came out a couple of years back to really showcase how important it is for doctoral education, something I will come back to again in this presentation. But as Dan has said, all of that led to an impact that I could never have even planned. You don't plan this stuff, it just kind of stays going. It's coming back. Yeah, I mean, we all like to present that we had some kind of career plan that we ticked off as we went along. That's not how it works. Yeah, some idea of the direction of travel, yeah, goals, yeah, some areas we're trying to target, but I think that it's somehow some nice, neat career thing is really a misnomer. And I have this conversation a lot with people at the moment around workload management, time planning, you know, how we fit in all of these things. And, you know, my mantra often to them is, well, the more time you spend trying to work out how you fit something into that last 5 minutes that you have, the more time you are wasting in actually doing the work. And we get kind of obsessed with counting hours, and we're often driven into by some of our organizational structures that aren't that helpful. But actually the reality is that to do this kind of work, you have to be thinking creatively, innovatively, and not in some kind of linear box type way. It requires that extra mile all the time. And again, something I think we need to talk more about is in our clinical academic career processes in particular. Lost track of which mouse I'm on now. So the impact of all of that work has been amazing, and Tanya and I constantly kind of look at this and think, how did that happen? And it is just this constant picking off of the next question, the next issue, the next agenda that needs to be addressed. It's not a short journey, it just goes on and on and on. And the person-centered practice framework has had an amazing impact globally. out in the UK Research Excellence Framework, where we were ranked as being global gold standard work. Because of the kind of depth and breadth of the work and the impact it's had on different aspects of care, on education, on policy, and on strategy, and it's now translated into about 17 languages. I think this is slightly old, but it's never enough. I think the question is that is that enough? Is that enough to then say, okay, that's where we stop? And anyone who is interested in research knows that there is no stop. It just stays going. There is the next question, the next issue, the next challenge that we want to take hold of. And I guess that's where I'm at now. Again, it's another phase of challenges. My colleague, Professor Royanne West, who's one of the most famous Indigenous nurse researchers in Australia and globally, who is a colleague at Sydney, we are doing some interesting work. I'll come back to in a second, but she said to me, well, if this framework has been so successful, then why is it that my people are dying unnecessarily in this country? Pretty profound question, I thought. Which has led to a whole program of work, I'll show you in a second, that we've been engaged in. And a really important question. And actually significant that it kind of did knock me off my perch for a while, and we had some great conversation about that issue and why it is that there is this gap, which I'll pick up again at the people-centered work. So where I'm at now, well, I guess you could say that's achieved an awful lot of outcome and enough impact. But we are in another phase of that 10-year kind of cycle of development. And what we're in now is this post-humanist period. This period where the kind of boundaries between person, human, non-human has become very blurred. It's become very blurred through AI, through digital health, through digital technologies, through all of those things that have actually challenged very heavily some of the concepts of what it means to be human. And even more so what it means to be a person. And we don't have time to talk about the distinction between human and person, but there is a distinction. But we are in that period, and there's been a special issue of nursing philosophy recently that just focused on post-humanist nursing. And what does that actually mean? Something that I think is now really critical for us to get our heads around and to understand. We are obsessed by digital technology, there's no doubt about that. Digital technology is everywhere within our healthcare. Whether we're accepting it or whether we're evolving with it, I think is a big question that we're asking and we're starting to try and do more work on. But it's also interesting in that the amount of digital technology that we have in the system does not correlate with the amount of evidence that we have about its effectiveness. In fact, quite the opposite. When you start to really dig into the evidence base around digital health, digital solutions, digital technologies, the evidence base is pretty poor and largely driven by commercial organisations who have an interest in this work happening, or by private industry in the health system, which is also driving a lot of it. So we have a huge question to ask here, which is, do we just go blindly, say, going with digital solutions when we know that in that space, the idea of the person and human is getting compromised? And what do we have to do to try and link with some of that, to really think about some of those new challenges that it means for how we engage as practice? Paul Tournier, who I mentioned earlier, talked about in his work around why physicians need to go beyond the diagnosis, that we only ever reveal parts of ourselves. We don't reveal the whole person when we're made, and we reveal part of ourselves over time. And I've deliberately placed that challenge to us here, because one of the biggest issues and concerns that I have currently is electronic records and the loss of the person in EMRs. And if we ever think that somehow having a predetermined algorithm or criteria for assessing a person is going to give us a comprehensive assessment of a person, we are totally deluded. That is just not going to happen. But that is what is happening. That is what is going on right now. And there is very little work happening to personalise and make person-centred EMRs. Even in the home, that's where I was working on. Whilst there is a language of person-centeredness, the reality of what's happening in the assessment process itself is not that. And so we have to ask ourselves, what does that mean for the kind of care that we want to provide? What I get concerned about is that the consequence of that kind of record is that we get more and more task orientation. Because what we are actually doing is allowing those algorithms to highlight the key tasks that need to be done. It doesn't say who's the best person to do them. We determine who might be doing them. And in a Australia right now, probably less so since the elections. The key challenge is that it's not always registered nurses who are being identified to do those tasks. In fact, often not the case. And where does nursing care and our notions of care fit within that context? In the university sector, we're being challenged heavily yet again as to why it is that nursing needs to be in the university sector as the TAFE starts to grow and grow its business. So again, these are all existentialist issues for us as a profession, that we can't just blindly think, oh yeah, this was great, it really helps. There is little evidence to show that it helps in time management, more efficiency, all of those kind of things. I'm not against it. I am just saying we have serious work to do if we are going to make it work for us rather than us working for it, which is where I think we are currently heading. And so person-centered practices privilege relationships of tasks. And so whatever we do in this phase, how do we ensure that it's the relationship that's kept central to our care decision making and not the list of tasks that we tick off on a day-to-day basis? Now, I know there are some fantastic practices happening here in this district and in every other health district that are not following that route. But when I listen to students, when I listen to colleagues, when I listen to directors of nursing even who say, yeah, that's what's happening, then we do have an issue that we need to put some evidence base to. Patient safety movement, I think, has added to this idea around the task around what we count as quality care. For me, patient safety should be a given. It shouldn't be the gold standard of what we're talking about. A safe patient experience should just be an expectation that everyone has. Now that's idealism gone wild, but the reality is we're all human and people make mistakes, and of course things go wrong. But if our only ambition is to keep people safe, then we may as well just turn all the algorithms and put robots in and get AI and just have everyone in there, because that's the best way of keeping people safe. But if our ambition is beyond that, if our ambition is to really elevate what it means to care, what it really means for a person to go through a caring experience and come out feeling a lot better as a person from it, then we have a lot more to do than just provide that kind of work. And again, Paul Tierney, I think, really summed this up really well in relation to what we choose to measure and evaluate. Again, it's really important when we're thinking about nursing research. Because what Tierney argued is that those kind of areas that we place heavy emphasis on in evaluation of patient safety, for example, miss the deeper connection of persons. It misses what is really truly at the heart of who I am as a person, that kind of spiritual dimension of who I am, the kind of personal communication that I engage with myself or reflexivity, or the way I reshape and shape who I am as a person through a care experience. None of that really gets evaluated through audits, through those kind of keeping people safe mentality. Not to say that they're not important, but again, we have to really think about how we think differently about how we're evaluating that work. And I have lots of I have lots of stories of care that I can share with you to illustrate those points. But I've been more connected of late with the Lancet Commission, where we're using stories of care. So the Lancet Commission is trying to take the principles of person-centered care and elevate it into a people-centered, systems-wide model for universal health coverage. Something that WHO has been working with for about 15 years, but has had very little impact for a whole variety of reasons. And I'm leading one of the programs of work in this commission, which is around no surprise here, definitions and frameworks. And in that work, we have about 20 different countries, people from different countries represented in that work group. I was online with them this morning at 5:45 a.m. running a workshop. So it's truly a global group. And last week, we held a Stories of Care session with these 20 plus people from all around the world. So we have people here in Australia, in Europe, US, Canada, many of the African countries in India, South Asia, all of them kind of represented. And we each use a creative process to embody stories of care, to kind of tell our own stories of care from our own care experience. So rather than talking about them, what about us? What does care feel like? How does it feel in my body from the experiences I've had? And I've had recently some surgery that I was very able to draw on very easily in terms of the care experience during those few weeks. And so these stories of care from 20 plus countries all had these common dimensions to them that I've listed here. I think most of these dimensions we would recognise as challenges to us on a day-to-day basis here in Sydney, irrespective of the LHD that we're working on. But I guess the one that really shone out in all of this was that last bullet point, which is that good care is not economically dependent. So we heard some amazing stories of care from a colleague in Delhi and the story of her father's stroke care in a public hospital system in New Delhi in India. We had a horrendous story of care from a colleague here in Australia, not the States, as well, of the care of his 4-year-old son, having had surgery recently. And the contrast between the economic ability of those two countries is incredible, but yet the worst care was told from here in Australia. And so we do know that good care is not about the money. Money is important, but the economy, we see good care in low economic countries, poor care in high economic countries, and everything in between. So these stories of care are really starting to illuminate some of these challenges around the digital space, post-human space, the indigenous space, and how it is we bring all of that together into a concept of care that actually holds all of us in the work that we're trying to do. My concern about my slides, all of this is that in The Wizard of Oz, the Tin Man had no heart. And he knew he had no heart. And he was desperate to have a heart. And he went in search of a heart, which is why he did all the stupid things he did. He was desperate to try and find a heart. My real concern, without being overly melodramatic about it, is that we're stripping the heart out of nursing. That we're stripping that heart that truly is the thing that has held me in it for 45 years and held many of our other colleagues in it for that time. Because we cannot reduce persons to algorithms and something we just do things through. So I would ask us, in our thinking about research going forward, to really think about care and what it means as a really important research question for us to be asking in this post-humanist digital space that we're in. We have to think about the kind of bureaucratic metaphors that we need. We can't just stand back on the kind of humanistic principles of the 80s and 90s that I grew up with. We have to really think about language and the concepts that are there, but we have to keep that notion of care central to it. And hence research culture and the kind of work that you're doing here is so critical to this agenda. And actually this LHD is so set up through the strategy and the focus you have to really take this on quite seriously. Not as an adjunct, but actually something really quite seriously. Research culture is so important in these kind of areas in clinical practice. It is the curiosity, it is the engine behind good practice, it is the engine behind innovation and how we all do our work. But actually, this is an excerpt from an online newspaper, a US paper, that again in the US, which are one of the huge challenges at the moment, the National Institute of Health had its budget slashed by billions of dollars, and nursing has lost out massively in that, which is really shocking. And what this online paper highlighted is the problem there is for nurse scientists, we would call them clinical academics, trying to balance doing care work and doing research work. And the fact that we are still so far away from a model that really works well for everyone. The kind of challenges which have been highlighted by Caleb Ferguson and Johnson and his colleagues who did this great paper. If you haven't read this paper, it's really well worth reading, around the challenges around clinical academic careers. Really shows the kind of problems that we're trying to address, and some of the work we're doing in the Council of Deans for Nursing and Midwifery in the research portfolio is trying to pick up on some of these, working with these colleagues. But there are huge opportunities, as your programme demonstrates. There are massive opportunities for this LHD and every other LHD to partner with people like me, like my department, and other schools and other universities, to have a really strong focus on how we support and create these kind of career structures that enable these important questions to be asked. We do need strong programs of clinical research in nursing and midwifery that are not just, held together by a shoestring, which is often how they are. It still baffles me completely why it is that we're able to accept that, probably here in St. George, a hospital like St. George might have 100+ medical professors, and we have one. And somehow we think that's okay. And I don't find that okay. In fact, I still, as I tell all my LHD colleagues, I still find it offensive that we think a lone director of nursing in an LHD can transform the whole nature of nursing and midwifery practice. rubbish. But yet, all of our LHDs are packed to the hilt full of medical consultants who have professorial positions with my university and UTS and every other one here. So that kind of abject imbalance and inequity is something we have got to fight, and have not just got to stand and take somehow. That's how it is. We do need strategic leaders like Kate and Tobi and everybody else to kind of really own this agenda. Because we need it happening at all kinds of levels. It's not about clinical nurses fighting their corner alone. It really has to be a strategic agenda at every layer of the organisation to try and shift some of these issues that I've listed here. And there is quite a lot going on at the national level in Australia. So Council of Dean's Research Advisory Committee, which I co-chair with Tom Buckley, is doing a lot. We're doing a lot around career structures. The Australian Nursing Midwifery Clinical Trials Network, really elevating the place of nurses leading clinical trials across Australia and New Zealand. And ACON is the Asian Pacific Quality, I can never think of the acronym properly, but it's Quality Research Network. Again, ran out of the University of Hong Kong, but it's collaborators across Australia. So these are really powerful networks. We need strategic leaders to be challenging and making things happen at these levels. So, what am I doing? That's easy to just say, well, that's all for you to do. Three things I want to highlight before the end. Okay, perfect. So firstly, at the University of Sydney and Sydney Nursing School, we're launching an initiative called SID-SAFE, which is now up and running for about a year. Our intention is to get it to be a multidisciplinary research centre in the Faculty of Medicine and Health, where as a school, we're leading the agenda on patient safety for the faculty. And as part of that, we're leading this initiative called SID-SAFE. And what we're trying to do is essentially address the issues I've been talking about. Patient safety research, human factors or behaviour change research, and person-centred research all happen as separate pillars. It may be the case with you too, but in most organisations, they happen as separate pillars of work. And if we're going to shift this systems-wide agenda, we've got to bring those things together. So we've deliberately and intentionally appointed professors to lead, to bring this together. So Mel Dasari is an expert in human factors. Claudia Rutherford is an expert in patient-reported outcomes, and we're shifting it to person-reported outcomes. How do we shift that agenda along? Her work has mainly been in cancer care, but she's now with us in nursing, in a more generic role. And what we're aiming to do is to create a systems design agenda through research to really rethink, what if we look at the overlap between person-centred patient safety and the digital agenda, for example? What does that mean for the way we do practice? What if we look at the overlap between patient safety and human factors, i.e. more digital stuff as well, and the way work systems happen? And if we start to intersect all of these, then what does that mean for the way we design our care systems? Because they would look very different to how they are currently. And we're just got some new research projects starting to kind of look at some of the intersections between these particular areas of work. The second thing, which Dan mentioned, is that I have the privilege of being the chair of the care programme in the Sydney Policy Lab, which is an academic policy unit. And that started with the Australian Cares Project, which I think I've talked about here before when you launched the strategy, which was an initiative funded by the Ramsay Foundation for us to really rethink what does society mean by care when post-COVID, when everything seemed to get thrown in the air. And it's a brilliant thing to ask. What do people out there in the community want from care? What do they mean by care? How do communities care for each other? And all of those kind of things. It's a starting point for where we're at. And Australian Cares ran a series of care labs. We ran people's assemblies, both in Metro Sydney and out at Broken Hill. And then we ran a policy lab with policymakers in Canberra, actually in the Parliament, which was a fantastic experience as well, to try and, as I said, go up their noses in it and get them to kind of really think about it as well. And from that, we developed principles of care, these 4 core principles, which are now forming the basis of the work we're doing through the care programme and into the various schools, including nursing, that we collaborate on. And these are 4 very simple principles about what we want from care, what care is, and how people people expect to be cared for and about. And for me, it's a very good kind of benchmarking approach to think about some of the challenges that I've been raising. In the People's Assemblies, I'll never put a timer on here, but hey, in the People's Assemblies, we picked up some things, particularly from immigrant populations who we spent a lot of this work with in the People's Assemblies, and we have put forward some proposal for new legislation on care visas, for example, so that extended families are able to provide care for each other, which is a real challenge here in Australia, as well as some other things around the funding of long-term care, the funding of care, and how community assets can be used to support care in community. And where that's at now is that we have the care program. If you go online, this is the website you will find. And what we're doing is essentially building community-led policy, community-embedded projects around care, and then using those community-embedded projects to challenge policy, to create new policy agendas around the way care happens. And one of those is some work we're just starting around a review of digital policy in the context of community and person. And so my research program at the moment, having gone from that very beginning of that negotiating partnership book, now looks something like this. So my research program intersects Sydney Nursing School and faculty with the policy lab, where my work kind of runs through those areas. One project led by my colleague Maureen Dunmore is working with adults with dual sensory impairment, so older adults who are deaf and blind, who get a terrible care experience wherever they go, and that is trying to look at a whole new model of community support for people with dual sensory impairment. Brains Telehealth is a huge trial and intervention study looking at the use of telehealth in residential care and how we use telehealth in a person-centered way, and it's based on the person-centered practice framework, but looking at both video and phone options to support older people to stay well in residential aged care. Publicly funded physio is a project led by a colleague in School of Health Sciences to make physiotherapy available for everyone in Australia rather than how much you pay for it. And really kind of shifting what we mean by publicly provided physiotherapy to all kinds of populations. The Social Determinants of Health is a program we're just starting in Fairfield in Western Sydney, which is community-initiated, community-led mental health services for women from CALD backgrounds, particularly focusing on refugee and immigrant women and their access to mental health services, but co-designing with them the kinds of services that will work for them in their community rather than what we might want to provide for them. Oz Hearts of Care, as you may have seen announced yesterday, is a $5 million project led by my colleague Neil Chapman, and I'm one of the CIs on that, to bring in a heart health prevention strategy into rural and remote Australia, which we just kicked off yesterday actually. And then Backs for Health is what I'm really excited about. Run out of University of New South Wales with us as a partner, where we're looking at person-centered approaches to the vaccination practices of children with intellectual disabilities in schools. So it's working with nurses in schools and with educators to help them develop more person-centered approaches to how they help children with intellectual disabilities to be vaccinated. Because at the moment it's quite abusive. A lot of restraint, a lot of bad practice in that space. So it's a really interesting space to get into because it takes person-centeredness into school and work with teachers to try and help them to create a context where that can happen. And then lastly is a new initiative launched by the lab, probably no surprises to those of you who know me, which is about bringing arts and cultural practices into policy development, which we've just got a grant to do some work on. So that's where I'm at right now. Moved from that one study through all of that journey of torture and hell and joy and all the rest of it to this program now, which is very exciting. And the last thing I want to mention is going back to Roy and West's challenge about, if your framework has been so effective, then why am I people necessarily? We are launching in January 2026 our new curriculum, which is the first in Australia actually of a fully integrated, indigenised, decolonised curriculum for nursing. We've just been through ANMAC accreditation with shiny stars, which is amazing, but it brings together both Western ideas of person-centredness with Indigenous knowledges of person and country and culture and Indigenous ways of knowing, and we're absolutely in a huge culture change in the school to re-educate everyone about how to actually run a program in this way, which is a massive task that we're right smack in the middle of right now, and very exciting, really, really exciting. So to conclude, a couple of comments going back to Boy, who has disappeared. Sometimes that might seem like a and it can just feel like overwhelming, but actually this step today and what's been happening up to this step is the first big steps towards this journey. And what a joy to be in a place where actually it's valued, where it's supported, where it's promoted. And as this second quote says, all of the issues we need to be addressing are right under our noses. We don't need to be looking elsewhere for those questions, those issues, those challenges. They are sitting right in front of us. And we just need to be curious enough to be asking them all the time, and then have the infrastructure in place to support it. And you just take that next step, and who knows where it's going to lead you. Thank you.
So much, Brendan, for an inspiring presentation and for sharing your journey with us. It's absolutely. Have a seat. Thank you. Whilst we don't have time for questions at the moment, Brendan will be joining us across the morning, so please make sure you do grab him and have a conversation. As I'm sure you can tell, he is a wealth of knowledge and an incredibly inspiring human. So please join me in thanking Brendan again for being here. Okay, well, we will move into our first session of today, which is very exciting to kick off our local presentations. And I would like to welcome our session one chair up this morning, which is Jane McGuire, our Executive Manager and Director of Nursing at Uniting War Memorial Hospital, to chair today's session. Thank you, Jane.
Thank you, Dan. I think I'll repeat the word inspiring in that as well. I had it written down a few times there, Brendan, during this session. So I think, certainly inspiring, I suppose, the why for building a nursing research and innovation platform. But now, as you say, it's time for us to hear from our district nursing research and innovation flagflies. So good morning, everyone, and those online. I'm not sure which way I'm looking, but I think I'm in the right spot. And I guess just to frame it up, I think, Dan, you've probably advised all of the speakers, and just for everyone in the room, each speaker on the topic will have 12 minutes for their presentation, after which there will be 3 minutes for questions. So please have a think about that as people are talking as to what questions you would like to ask. So I think Mel is here as our timekeeper. So Mel is the polite timekeeper at the 12-minute mark. And then if it goes beyond that, then there will be an Irish Six Nations rugby anchor topic coming in. So that's just a little warning. So without further ado, I would like to introduce our first speakers for session one. So familiar to you all already, Dan Shaw, Nurse Manager, Strategic Priorities and Patient Experience, and Susie Murray, Nurse Manager, Leadership Development Facilitator, will be presenting on the district nursing and midwifery strategy. So their insights will provide a comprehensive overview of the strategic priorities and the leadership development initiatives that were shaping the future of nursing and midwifery in our district. So please join me in welcoming Dan and Susie.
Thanks so much, Jane, and good morning, everyone, and thank you for having us. Susie and I are here to share with you our journey with our Executive Director of Nursing and our Directors of Nursing over the last couple of years in developing our strategy for transforming person-centred cultures. So as Jane mentioned, I'm Dan Shaw, Nurse Manager of Strategic Priorities and Patient Experience. And we have the lovely Susie Murray, who's our Nurse Manager of Leadership Development Facilitator. And we sit in the District Nursing Midwifery team. So a little bit about today, we're going to take you through our journey, our collective journey. Susie and I were at the side of our Directors of Nursing throughout this journey. We're going to talk to you a little bit about the strategy, how we came up with our purpose and values and talk you through that, step you through the priorities and let you know where we're at now and where we're headed. So a lot of you would be familiar with the document on the left-hand side of the screen, which is our journey to care, and that expired in 2020. It was really the catalyst for us to take stock and consider the development of a new strategy that was contemporary and met the needs of our current nursing and midwifery workforce. We engaged with Professor Tanya McCormack, a close friend of Brendan's, and co-author of the person-centred practice framework that Brendan shared in his presentation. Tanya worked with us as a core group to commence this journey, and we focused the strategy development around the person-centred practice framework, and we'll take you through that through this morning's presentation. So it was quite a lengthy journey to get to where we are today. We had over 11 workshops virtually. I think we at last count was over 15, with Tanya McCants leading those virtually. So for those of you who aren't aware, Tanya lives in the north of Ireland, and we were developing this through the COVID years. So there are a lot of barriers in our way in terms of developing the strategy and engaging with Tanya. So we held those virtually, and we did a couple of face-to-face because we realised that certain sessions, such as doing our values clarification, needed to be done in person. We couldn't do those virtually. We tried and it didn't work. So we brought that into a face-to-face setting when we were able to. Tanya started working with our directors of nursing around really getting to understand the person-centred practice framework and unpacking that, understanding what it meant to each of them. And that work is, well over two decades in the making to develop that person-centred practice framework. So ensuring that as a collective group we understood the elements of the framework and how we were going to engage with that throughout the strategy development was pivotal. And what the framework really did was help us, and that work with Tanya was to really understand the relationships between the 5 constructs and the layers you can see in the framework in the top left of the screen there. And that, that takes us from the macro sitting around the outside right through to the outcomes, which are sitting in the centre of the framework, our healthful culture. So we undertook a values clarification exercise, and that really helped us understand the current values of our nursing and midwifery leaders around person-centred practice, and provided us the underpinning values for the strategy that you'll see in the strategy that you will have a copy of. Those values, Susie will speak more to as we move through today's presentation, but really underpin the work as we move forward and as a group. Our Dons worked in pairs to define our priorities, and as a group they came up with over 15 of those, and when we all came back together and looked at them, what we saw was a lot of overlap. So we were able to revise those back down to the 7 priorities you'll see in the strategy today. At stages of the work of the development of the strategy, we held virtual workshops, face-to-face workshops with hundreds of our colleagues from across the district. Some of you may have even attended some of those, and they were really pivotal in helping us understand how the strategy, what the strategy meant to you. Could you see yourself in the strategy? What needed to go into it? What we were missing? And really helped shape and refine the final version of the strategy. We held a town hall session that really spoke to the strategy and really invited our nurses and midwives in to understand the process that we were moving through and start to talk about the strategy, how it links with the person-centred practice framework, and how we were going to implement the strategy. We then went on a journey of ongoing focus groups that were held with our final draft, or our draft strategy, to really understand, could people see themselves in the strategy? Did it represent them as a nurse or midwife? And we had lots of fantastic feedback from those sessions that helped us further refine the strategy. We underwent an external review. It was really important for us to take it to our colleagues in other professions fields to run it through their lens and their perspective. It made sense to us, but did it make sense to them? We further reviewed that, designed the strategy, and it was launched, as Brendan mentioned, at the end of 2023 with both Brendan and Tanya present, which was absolutely wonderful. So I mentioned earlier the purpose, and I'll let you read that. I won't read it out to you, but this was a really pivotal point along the journey where we asked our directors of nursing and midwifery to consider what the purpose of the strategy would be. And coming together as a group, we looked at everyone's responses, and we were able to, over a series of sessions, refine this down to an overall purpose statement that would really define what the purpose was of our strategy and the purpose of what person-centred practice means to us in our LHD. We hope that when you read this that you can connect with it. I'll give you a few moments just to think about how that resonates with you. I'll hand over to Susie now who'll take us through the next part of the presentation.
Thanks, Dan. Do I need a microphone? Oh, yeah. Thanks, Dan. So quite a journey. It's been a wonderful journey. And so I'm beginning here now to share with you the values. So the strategy is underpinned by the shared values you can see here. And these actually build on the values that provided the foundation of the Journey to Care, 2015 to 2020. So care, integrity, respect, influence, innovation, and inspiration. So during the values clarification exercise, the Donhams agreed that these values, they redefined them. You can see that, you can read underneath them the definition. They redefined them, but really felt that they still aligned, and they feedback in the nursing and midwifery forums that Dan talked about. Our nurses and midwives also really felt that they resonated and connected and aligned to those values. So there was an additional value added, wasn't a trick, did you see? Of courage. So courage was added, to be brave and lead through our own use of voice and actions. So a really wonderful addition. So as we'd also like you to think about, when you look at these, hope that you can recognise, resonate with them, and hopefully as nurses and midwives across South East and Sydney LHD see these in action. What do those values look like in action? Okay, so these are, and you won't be seeing these hopefully for the first time, the 7 priority areas. So each of the priority areas has between 4 and 6 strategic actions within them, and these are what will guide us to really achieve the strategic direction over the next 5 years. Within the strategy, there are some hard copies, and I just, if you did want a hard copy for your toolkit, which they are like a toolkit, ours aren't they? Within the strategy are beautiful best practice examples, and we've got those so that we can really bring the document to life. And it's a celebration already of what amazing work and research and innovation is happening across South East and Sydney LHD. And it really enables us, staff, our teams across the district at every level to really recognise that quite practical evidence, and thinking about, could we implement that? How would that look perhaps in our setting? Really great sharing. And you can see on this lovely image, which is in the strategy, that the priority areas just beautifully align to the person-centred practice framework. And just part of that journey, the priorities came about, and then the alignment was really recognised and seen afterwards. Yeah. And as we'll hear today, everything that you present, all our presentations, aligning to priority areas, but really, as you listen to those, considering that alignment to the person-centred practice framework. So here it is on a page. And we've got some copies of those as well, some hard copies. Really nice posters to have to work with in your spaces, and the action areas for each priority area nicely visible there. So, progress to date. So this is where we would just like to say where we're at. Thanks, Dan. Because, you know, the time frame we've heard for launch of 2023. So since 2023, the strategy has been then launched in our local facilities. As you know, we've got lots of facilities within the district and services. So they happen 2024 and also throughout 2025. Then in progress, and again, obviously starts at the beginning and is continuous. We've got evaluation and implementation of the strategy. So this is where we've, the Directors of Nursing and Midwifery, have workshop with Tanya McCanns, Professor Tanya McCanns, and also Professor Val Wilson. And they are going to be looking at further workshops in the future around that co-creation of the evaluation framework. The evaluation and outcomes of how we measure the effectiveness of the strategy, those helpful cultures, that person-centeredness. So the approach will be multi-factorial, mixed methods, and of course qualitative, quantitative. And lots of just quick examples would be the person-centered KPIs, as Brendan's talked about, the stories of the patients, the consumers, and stories of our staff. What's it like to be here in South East Sydney LHD? And very quickly and importantly, local governance structures are underway and in each of our facilities where we work around aligning the strategies to our bodies of work, and the shared governance framework within the district is underway. You've not heard, we've actually got a governance group for each of the priority areas. Representation within those groups from every facility and service. That's shared governance, so we've all got a voice and we're all involved in working towards those helpful cultures and person-centeredness across South Eastern Sydney LHD. And a very quick note, can you see at the bottom, publication journal? We can update that. We actually got an email, you won't believe it, last night from Frontiers to say that we've been accepted. So our paper of this journey is about to be published. We'll keep you posted.
All right, thanks very much, Dan and Susie. Timekeeper Mel, how much time would we have left for questions here? 2 minutes. So have we got any eager questions coming forward on the strategy? Kate, you? No? It's like an auction if you move. The bid's yours. I guess if in the absence of one, I might pitch one your way, Dan and Susie. With the governance group starting, I'm just mindful of your last slide, Brendan, where you mentioned around the horse and that, and saying that the first step is the important step. So some of you might already be nominated into the governance groups and others might be interested after today. So I guess is there a pitch that you would put to anyone in the group to join in the governance groups?
Absolutely, I guess. In terms of our governance groups, we have some set membership that is quite intentional. However, I guess what we're looking at developing later in the year is a community of practice where we would invite nurses and midwives at all stages of their career into that space to be able to participate in that community of practice.
And I think what's important is with a shared governance framework, and it's still draft, the visual and how it looks we have to, is that locally you've got your local structures around the strategy, and it's how that we can bring that into the governance groups both ways, and then obviously to the Directors of Nursing and Midwifery, that reporting.
Excellent. It's a bit tempting wearing blue suede shoes and having a microphone on. I'll do that to you, it's too early. All right, so next up, we have the very charismatic Brendan McCormack. I see you up there, Brendan. I've had the pleasure of hearing Brendan in full flight describing his work in the CAU at Prince of Wales. So welcome, Brendan. Brendan, our Nurse Unit Manager of the Community Assessment Unit at Prince of Wales Hospital. Brendan will be discussing the critical aspects of establishing and maintaining a person-centred culture within healthcare settings. And his experience and dedication to patient-centred care will provide valuable insights for us all. So please welcome Brendan Shanley.
I don't think I've been called charismatic in a while, so that's nice. Thank you. Thanks. I'm really honoured to be here today to present this work. Ruth Smoother is the principal investigator on this. I'm one of the CIs along with Sue Shepherd in the room today as well. And I'm going to do my best to sort of explain what we've done over the last year and a bit. And I think it will give you a different insight into how you can operationalise this at the unit level. After hearing from Brendan and hearing from the district team, bring it down to the unit level to establish and maintain that person-centred culture. So we have aligned our strategy to priority area number 7 of developing person-centred cultures. Priority area 1, developing person-centred cultures. Specifically, our strategic action 1, 2, and 3. Strategic action 2 specifically of using the findings and outcomes to create a workplace culture that aligns to person-centred values and positive behaviours and enhancing relationships within and across teams through authentic engagement, as well as our alignment to priority area 7 of delivering high quality, safe person-centred care. And we've demonstrated that through the primary goals and outcomes of the Community Assessment Unit and its model of care, which is an innovative and holistic model. We've also trying to demonstrate that we're ensuring that the person's at the centre of what we do by providing access to holistic care that's flexible, coordinated and collaborative, by using evidence to assist in the development and delivery of person-centred, high quality and safe care. This is some qualitative research and we're going to demonstrate, it's been demonstrated by our evaluation to the Prince of Wales Quality and Safety Culture Framework and its influence on the community assessment units, registered nurses, and their perceptions of ward culture and person-centred practice in a new team, on a newly opened ward, and as well as attempting to determine if the preparatory phase of our quality and safety culture framework has influenced workplace culture and the CAU registered nurses' perceptions on person-centred care. So just a little quick background on the CAU at Prince of Wales. We opened on the 1st of May 2023. It's part of the Acute Services Building redevelopment. We provide a general medicine community-facing model of care, which offers inpatient and outpatient facilities. Patients who are 16 years or over, not experiencing an acute medical episode and would benefit from a multidisciplinary approach are eligible. And our target length of stay is 48 to 72 hours. Our key strategy of the CAU is to reduce the patient length of stay without compromising the person-centred care and to improve the pressures of patient flow and access within the emergency department. CAU needs a nursing team that is built on the foundation of Prince of Wales Quality and Safety Culture Framework, and we need them to be able to drive the workplace culture conducive to a positive experience for them as staff, also for our patients and their families. So what were we trying to do? Well, we had the title of our presentation as Establishing and Maintaining a Person-Centred Culture, laying the foundations for a person-centred culture of excellence in a newly designed hospital ward. We had the opportunity to analyse a team that was new, in a new building, and delivering a new model of care. Our first aim was to evaluate how the Quality and Safety Culture Framework influenced the registered nurses' perceptions of ward culture and person-centred practice. And we were trying to determine whether the Prince of Wales Quality and Safety Culture guiding frameworks, elements of vision and values, assessment, feedback, action planning, implementation and evaluation were understood by the nurses. Secondly, we wanted to align strategies from the preparatory phase of the Quality Safety Culture Framework to determine if this had an influence on workplace culture and if it had an impact on person-centred care. So the Prince of Wales Quality and Safety Culture Framework up there as Figure 1 has been implemented across all clinical units at Prince of Wales, and it's underpinned by Figure 2, which we've heard a lot about today. Brendan and Tania's work on person-centred practice, and using this framework to assist in operationalising person-centredness within clinical context, and to establish a safe and positive workplace culture that prioritises person-centred care. So the first activity which came from the framework in our preparatory phase was to develop a vision and values session. And that was completed by the CAU CNE, Sharon Finn, who's in the room today, and also included the medical and allied health teams to determine what the values of the CAU were. From this, we were able to develop a vision statement, which is up there, which reflects what we're all working towards in our day-to-day practice, our purpose, our outcomes, and how we involve all people in the care that we provide. It was important in this activity to include the medical and allied health teams outside of us in that, but outside of our study, the nurses work with these teams and their colleagues day in and day out. The vision statement, based off a shared collection of values, is the key component of the Prince of Wales Quality and Safety Culture Framework, and it centres around the shared goal of achieving a healthful culture for our community and our workforce. So the second activity for the RNs to complete the preparatory phase was probably their favourite. It was aligned to the Quality and Safety Culture Framework, and it was for them to voluntarily complete the well-known Dove, Owl, Peacock, Eagle personality testing. It was an eye-opening experience and highly valuable exercise, which was completed by everybody in the CAU. And it was an opportunity to know more about ourselves and each other, how we're perceived, how people interact with and how they interact with different personalities. It was really valuable as a new team in a new service. Staff were able to complete their self-assessment tools to then reveal insights into their personality type, to understand their traits and their preferences, their strengths and their weaknesses, which in turn led to personal growth, development, and the ability to improve communication, collaboration, as well. Participant 8, when they were going through their interviews, which I'll talk through shortly, referenced this in their narrative in the context of having positive feedback about engaging with their colleague. The participant stated, "I'm not sure how you did that, but it's like you matched our personalities, and that made me understand why I'm like this to this particular person." The CAU don't mix is a Peacock majority, which might not surprise you, but that indicates that CAU nurses are positive, confident, emotional, and flamboyant. Often, the Peacock is, they thrive in social settings. I've just been given the time check that everybody got the good stuff. Alright, so, moving along. A descriptive qualitative methodology using in-depth semi-structured interviews was conducted. Following ethics approval, a group study invitation was circulated to nursing staff working in the CAU. The email provided a summary of the study, a copy of the participant information sheet and a consent form, and it was completely voluntary. In-depth interviews were completed face-to-face in a private room, and the participants were given an interview guideline. There were some open-ended questions. Participants were provided with an individual numerical code to ensure they remained anonymous, and the data was able to be withdrawn up to the point of the thematic analysis. Audio data was transcribed verbatim in the interviews, and the data was analysed using Braun and Clark's 6 steps of thematic analysis. And we viewed that through the person-centred lens. So just onto the results. We had 8 registered nurses with a mean age of 35. There were 3 dominant themes and 7 sub-themes that were identified. So theme 1 was setting the foundations for a positive culture. It was the first dominant theme through the thematic analysis. Participants spoke about leadership at all levels, through the micro, meso and macro levels of healthcare as outlined in Brendan and Tania's person-centred framework. The framework was demonstrated in the context of the quality processes that had been implemented in the preparatory phase of the framework rollout, which included the vision and values that I've spoken about and the personality testing. Disruptors of culture were specific within the ranging levels of skill mix, which had an impact on the mood within the ward. And a key quote which stood out was, new people come into the team and they just change the dynamic. Theme 2 was embedding a culture of safety. It was the second dominant theme. There's some quotes up there for you to read. And the narratives demonstrated that the person-centred care processes and quality and safety culture framework activities were embedded as routine practice, and that a standard of care was supported by the leadership team. Participant narratives also indicated that they had a positive impact on psychological safety of staff, and that was highly valued. The next theme, the final theme, was the aesthetics of the care environment. Not talking about the colours of the wall or the natural light in the new ASB, it was more aligned to coming to work in a supportive space and being connected as a team. The environment and the team dynamics were described as reinforcing a positive culture, and good communication and person-centred practices were noted as integral. So, in conclusion, we concluded that to deliver a healthful culture, we need to provide a values-driven and safety-oriented approach to person-centred care. Implementing a quality and safety culture framework is important for the establishment of a positive ward culture. We found that by completing a shared vision and values statement, incorporating the structured quality processes and support from nursing leadership team at all levels, enabled a values-driven and safety-oriented approach to person-centred care, even as the hospital dynamics evolve. We concluded that to sustain a positive culture of excellence, regular evaluation is required, and if this study was to be replicated and scalable, the disruptors of the ward cultures need to be identified. They need to be carefully considered and trigger a reset or revisit on the activities used to shape the quality and safety culture outcomes of the service. The dynamic nature of the disruptors were identified in the interviews demonstrate that they do have an ability to alter the ward culture. This study highlights today how implementing a quality and safety culture framework and associated activities does lay the foundation of a positive ward culture, and this is driven by nursing leadership at all levels. Establishing a shared vision, structured quality processes and support from the nursing leadership team and their approach to person-centred care is vital. We recommend being strategic with the timing of similar studies and ensuring that the participants are familiar with the steps of the framework that are guiding the quality and safety culture outcomes of the service. We also recommend there is engagement from various stakeholders at the micro, meso and macro levels of healthcare in their approach to prioritising a healthful culture, and to take into consideration how our research can be applied to different clinical contexts as a strategy to delivering person-centred care. The thematic analysis added an element of rigour along with ensuring that the findings were robust and credible, which added value to this study. The Polly-Clark 6 sets of thematic analysis identified the dominant themes, which weaved across and within all of the interviews. I'm out of time, I've got one paragraph left. We found advantages within the design of the descriptive qualitative study, which allowed for an in-depth understanding of the nurses' perceptions of the preparatory phase of the quality and safety culture framework and its impact on workplace culture. The descriptive nature also allowed us to articulate a coherent story, and that's really important, of the registered nurses' perceptions of the person-centred practice, and of the Prince of Wales quality and safety culture framework. Thank you.
Excellent, well done. You've covered a lot in that time, Brendan, and we've got a question off the back there. You've got a roving mic, I think.
Brendan, lovely presentation. Fabulous work of the utilisation of the quality and safety framework. My question is, or can you explain a little bit more about, you mentioned about one of the themes was aesthetics in the team. What did that mean, and how was that represented?
So when we were talking about that, it really came down to having a supportive space, so through the nursing leadership team at all levels, and the connectiveness between the staff. So did they feel safe to come to work and to talk about their experience and to share what they were experiencing in their day-to-day, and how the leadership team supported them when it was a particularly bad day or as our model was evolving. And, you know, I think it summed up, one of the key quotes that summed it up really well was, I think that we're trying to involve the patient in their own treatment and their choices, which is important. We have each other's backs, we are supportive of each other, And I've never felt like I've been at the bedside and somebody hasn't wanted to come and help if I needed it. So that's what that aesthetics of the care environment was alluding to. Thanks.
Sorry, and I was just going to add to that. It was also about the participants' willingness. They wanted to come to work, and if I recall, one of the quotes spoke about how they referred to coming home.
Yeah.
Going to work was like coming home, and it was just so beautifully presented. I think that feeds into that.
This is Sue, who was one of the CIs in the study. Thank you. Any other questions?
That's nicely rounded out, Brendan, and thank you for the questions. And certainly, thank you, Brendan. I guess we often talk about building the planners who fly, and healthcare that is a really good example of building everything from the ground up, Brendan, so thank you for some very good food for thought there. Our next speaker is Liz Turner. So Liz is our research nurse coordinator for critical care medicine at Sutherland Hospital. Liz will be sharing her expertise on the pivotal role of the research nurse in critical care medicine, highlighting the impact of research on patient outcomes and clinical practice. So let's give a warm welcome to Liz Turner.
Okay, good morning colleagues. My name's Liz. I'm the Research Nurse Coordinator at Sutherland Hospital in the Department of Critical Care Medicine, colloquially known as CCM. It's the Intensive Care Unit. And I'm here to present a topic about how we developed my role, that of the Research Nurse Coordinator. And this role has really been integral to the development of our working towards our priority of building research capacity. Today I'll talk about why the role is important, how the role came about, and the progress that we've made, as well as some of the challenges that we've encountered along the way. I've been the incumbent of the position since 2021, so I'm pretty much the first person to do this role. And I'd like to acknowledge my colleagues, Associate Professor Anas Naeem, who's one of our intensivists, Laura Fagan, Kelsey Matthews, Emily Ryan and Kari Feder, our mum. Unfortunately, none of them are able to be here with us today to cheer me on. So yeah, thank you for that. And I'd like to acknowledge the traditional owners of the lands on which we're meeting today. So really the priority that we address in this role is that of building research capacity. And as I'm going to talk about today, the very existence of this role has undoubtedly meant that we have built some research capacity within our department, and we've achieved that through a number of various actions. All staff have the opportunity to nurse patients who are participating in clinical trials, meaning that all staff are being exposed to the many aspects of research practice, and this in turn ensures that there is equity of access for all staff for learning opportunities to learn about how we do research. Secondly, the CCM research nurse role with this fine focus on research means that there is a support pathway for anyone who wants to pursue research in the department. Thirdly, we're now starting to be able to utilise some of the evidence that we've been able to generate through some of the trials that we've participated within. And finally, through presenting our results through regular in-services, through meetings, through presenting at forums such as this one, as well as having our contribution acknowledged in publications. We've had a couple of those. So the research team is able to really celebrate what we've been able to achieve. So just a little bit of background. Since the development of the intensive care unit about 60 years ago, there have been a number of changes that really have impacted upon our work that we're able to deliver. With advances in medical care generally, as we all know, we have now starting to see the rise of this ageing population. Our intensive care unit patients are older, they have more complex medical histories, they're often presenting with a raft of chronic health conditions. Furthermore, the patient care that we deliver is much more complex. We have quite invasive and highly technical treatment modalities that we're delivering every day. So with all these changes, it's quite obvious that we need to be achieving patient safety, and through that, getting a need for specialist clinical research. And subsequently, the conduct of clinical trials within the intensive care setting has become a specialised area. Following with these trends, there has been a growing interest among clinicians in participating in research. And in fact, there is really an expectation that in intensive care, we are participating in research. However, with CCM's first participation in a large intensive care clinical trial, it became very clear that the workload for coordinating all the trial, collecting the data, etc., was well beyond that of the existing staff capacity, in particular the CCM clinical nurse consultant. So indeed, this experience that we had is borne out in the literature. Research is increasingly expected as part of clinical nursing roles, yet issues such as short staffing, increased acuity of patients and inadequate resourcing is hampering our efforts. And in addition, specialist nursing skills are required in the coordination of clinical trials within the intensive care setting. Research nurses require specific nursing expertise that complements and yet is slightly different from the skills from the nurses that are performing the direct patient care. Hansen and colleagues note that the research nurse delivers both care for the patient as a research participant, but also they need to have care for the robust requirements of the research protocol. And as Ada and colleagues point out, there are some important ethical considerations that can add a layer of complexity to our work. So obviously, given that our patients are critically unwell, they're often not able to provide direct informed consent for participation. So it became very evident that a specialist nursing research role was required. And so the CCM leadership started to prepare a case to establish the role of the research nurse coordinator. And critical to this was the involvement of our RCU specialist Associate Professor Anas Naeem. He acts as our research champion, and he really strongly advocated for, in order for us to be participating in research, we really needed to have a dedicated research nurse coordinator in the role. So initially, one of the department's CNSs, who has an interest in research, she was upskilled and she took on a couple of extra hours and she was able to do some data collection and in essence to be testing whether the research role was a viable one, and her work demonstrated that this was possible, so the permanent role was established in 2021. And I should really point out that a critical point was that the funding for the role is derived from the research. So that means that the role is sustainable for however long we continue to participate in clinical trials. So here's a bit of a list of the roles that I undertake. So it's pretty broad. I'm responsible for management of research, ethics and governance. Anyone who's had any experience with Regis will know how exciting and wonderful this part of the job is. I'm responsible for participant recruitment, collecting informed consent, and this is really a key point, the care and the communication with our families and our patients. All the data collection, all the maintaining of the databases, I make sure that the protocols are being adhered to, and this is really achieved through a lot of support and education to the clinical staff. Pretty much I'm doing a little impromptu in-service pretty much every shift, so that I'm looking after the nurses on the ward, looking after our patients that are involved in clinical trials, and I'm also responsible for the study finances. And since the inception of the role, we've been able to participate in 9 studies, and that represents a 70% increase in participation in research in CCM since my role was established. So we think that's pretty good. At the moment, this is the list of the trials that we're participating in. So we're looking at participating in something called REMAP-CAP. It's about community-acquired pneumonia. We participate in STEP care, which is looking at intensive care intensive care treatment for patients after an out-of-hospital cardiac arrest. And just on that one, for our small unit, we're funded for 6 ICU beds. We're ranked number 33 in the world for recruitment to that study. React Shock, we're participating in. It's about individualised MAP targets in shock, and Tobi is looking at treatment for metabolic acidosis. We also participate in the ANZICS, that's the Australia-New Zealand Intensive Care Society Point Prevalence Program. That's like a snapshot that looks at all ICUs, what we're doing at any given point during the year. One of our own research projects that we've developed is the Sleep Quality Project, and I have a poster on that, so you'll be able to have a little look at that one later. And also we're heavily involved in the development of the CCM Green Team, and part of that Green Team we have presented recently a poster on our project looking at the safe disposal of propofol. But in doing all of that work, we have encountered a few challenges along the way. So when I came to the role, we knew that there was a requirement for me to hold good clinical practice GCP certification, but other than that, we weren't really sure what it really meant, that what my job was going to be like. There's a lack of defined guidelines and guidance for research nurse coordinators, and this is certainly borne out in the literature. The research into the role says that, or reports that, tasks undertaken by research nurses differs between countries, across areas within the hospital. My own experience was a very steep learning curve, but working as a research nurse, there is quite a lot of independence and of autonomy. However, that does lead to a bit of a sense of isolation, a feeling there's a lack of formal power. I'm part of the leadership team, but I'm not. And some research does point to that as well. Bachman Learn in 2024 described the role as being like the hub of a wheel, but without real power. And I would also add, gaining consent in ICU trials is quite challenging. It's difficult to get consent, obviously, when our patients are critically ill, and it can be quite fraught for our families when their patient is so unwell, and it's a very difficult time. Does that mean I could just quickly keep going? Do I need to stop? One more slide, which is there. But we really feel that we've made great strides. We have enhanced the culture. We've increased the staff understanding of the importance of research. We've made CCM an attractive and dynamic environment for nursing and to medical staff as well. And it really underlines the importance of nurses leading and supporting research. Thanks very much, guys.
Great, thank you, Liz. Have we got any questions from the floor or from online? I'll pop on to you then, Liz. I'm imagining, I haven't worked myself in the critical care space, not for a very long time, since student days, but critical care medicine is inherently multidisciplinary team sport. So how do you incorporate, where you've got your own research portfolio there within CCU, how do you collaborate with your multidisciplinary colleagues, particularly around the challenge of patient consent? From a nursing perspective, I guess, how does nursing work in with what we've heard about earlier as to often a very well medically resourced research faculty?
Yeah, I guess with our experience that we do have a multidisciplinary team in CCM. We work closely, we're a small unit, so we're like a little family there. I probably would think that the collaboration with the multidisciplinary team would come through our work in the green team. So everyone's invited to that, and we're all looking for how can we do some research around that space to increase the sustainability of our practice in ICU, because it's a very carbon emissions heavy area of the hospital. So that might be one example of how we do that. Yeah.
Excellent. Thank you very much. Give a round of applause for Liz. Thank you. All right. So next up we have a team. Quite a few names to read out here. So we have a Prince of Wales cohort. So it is our panel of speakers: Associate Professor Sue Shepherd-Law, Renia Lagunde, Daphne Chung, and Junwal Lee. And so this panel will be discussing the development of research capacity through a nursing research community of practice. Their collaborative efforts and diverse expertise will shed light on the importance of building a strong research foundation within our nursing community. So please join me in welcoming this panel.
So thank you everyone for a warm welcome, and thanks to the organisers for allowing us to present our work today. My name is Sue Shepherd-Law, and I'm the Associate Professor of Nursing at Prince of Wales Hospital, Sydney Eye Hospital, and also at UTS. RJ, Daphne and Junwal are my co-presenters. I'd just like to take a minute though to recognise the co-authors, because this would not have been able, this project would not have been taken underway without their support. This project aligns with building research capacity, and the actions are underneath, but it also aligns with delivering high quality, safe, person-centred care. I'm going to a little bit about how we established, but not spending too much time on that, implementation, but most importantly, the CNCs here will be talking about the person-centred outcomes that they are developing through their research. So to start with, what is a community of practice? So it is defined on the slide as a group of people who share a concern, a set of problems or passion on a topic, and deepen their knowledge and expertise in this area by interacting on an ongoing basis. The term was first coined by Etienne Wenger and June Love, who describe a community that acts as a living curriculum for practitioners to learn from one another, irrespective of their position within the organisation. What I mean by that, there is no hierarchy in our community of practice. The framework was first utilised in a business setting, however, it has been successfully implemented within healthcare. The nursing research community of practice aims to build and extend nursing capacity and capability to take meaningful, ethically sound and culturally sensitive research, but it can currently extend to postdoctoral research nurses and CNCs and engage them in research and connection to the academic community, which working clinical place often excludes them from. And secondly, to promote person-centred research outcomes that enhance patients' experience and staff's experience. SEMA has 3 core groups to actually establish. The core group here was Prince of Wales and Sydney Eye Hospital postdoctoral clinically based nurses and some UTS academics. The active group are the CNCs who are actively engaged in the research processes, learning, developing their own research. And the peripheral group are those who dip in and out of the research community of practice, not ready to engage, but just a little bit curious. To implement the nursing research practice, the core group developed a set of activities which are listed here. They focused on developing nurse-led research that is person-centred and authentically relevant to each of their clinical space and specialty practice. My co-presenters will now discuss their experience and research development.
All right, good morning everyone. My name is RJ. I'm the clinical nurse consultant for HIV and infectious diseases at Prince of Wales Hospital. And the title of my study is Attitudes and Perceptions of Outpatient-Based Registered Nurses in Facilitating Opportunistic and Immunisation, a qualitative study. So a little bit about me as a clinician. It's related to my research question. Part of my role is working in a blood-borne virus and sexual health clinic. And for more than a decade, we fostered and embedded a culture of providing vaccinations for our clients, particularly for people living with HIV and men who have sex with men. These vaccines include influenza, pneumococcal, hepatitis A, hepatitis B, zoster, and smallpox and pox vaccines. And these are routinely offered when they are indicated. And at this moment in time, select vaccines are supplied and listed as myself as an authorised nurse immuniser or prescribed by a medical officer. So as a researcher, I'm curious and I'm asking the question using a qualitative, descriptive focus group design. And I'm curious about what about other outpatient settings. So these include respiratory outpatients, oncology, renal, geriatrics, and general adult outpatients. I'll describe my study further in 5 phases. So phase 1 is forming a stakeholder group. And so at this point, I'd like to acknowledge the team members, Lillian Whalen, who holds the equivalent role here at St. George Hospital, Associate Professors Brendan McCormack and Suzanne Shepherd-Law, and Dr. Mohammed Juliami, who was assigned my academic mentor based at UTS. All these have been instrumental in assisting me into the next phase, which is protocol development and ethics submission. And understandably, it has been a protracted process, considering some of the complications when you talk about the topic of vaccination. And currently, we're now in phase 3, or preparing for phase 3, which is recruitment and data collection. So we'll be recruiting from both Prince of Wales and St. George. I know myself and Lillian, we're all novice researchers and we've never held a focus group ever, and so we've got a mock focus group scheduled in for next week. We may need more mocks to come. Ultimately, we like to collect the data and use these for thematic analysis and theme, and the end game will be designing models and pathways for opportunistic immunisations for those previously mentioned outpatient settings. Before I hand over to Daphne, I'll just say that being part of the community of practice has been certainly a confidence booster, and some of these things would not have been possible without the support of the team, as well as the other presenters of the workshops. I'll hand over to Daphne.
Thanks, Angie. Hi, my name is Daphne Chong. I'm the Community Wound CNC in Prince of Wales Hospital. So a bit of background as a clinician. We know that lower limb edema is one of the clinical manifestations of heart failure. And we also know that sometimes medications alone are not sufficient to reduce the edema. Having chronic edema can significantly impact on the quality of life of the person, and it also increases their risk to develop wounds and cellulitis. Historically, most, if not all of the international practice guidelines state that decompensated heart failure is a contraindication to use compression therapy for people with heart failure, with the fear that increasing the venous return and the preload would add extra burden to the already failing heart, and it may result in pulmonary edema. However, we wonder if there is actually any good evidence on this. Therefore, as a researcher, together with Carly Robinson, who is the TNP for heart failure in Shohaven Hospital, Jim McVeigh, the heart failure MP in Prince of Wales, as well as Associate Professor Sue Shepherd-Law, and my academics mentor, Adjunct Associate Professor P. Sinclair, we have developed a systematic review protocol, and it's on the effectiveness of compression therapy in adults with heart failure. The review is to identify, appraise, and synthesize the best available evidence on this topic. Being in the community of practice in nursing research has enabled me to challenge the status quo by conducting research to systematically review the evidence. We have published the protocol in Prospero. We are preparing to publish the findings and plan to conduct a clinical research after the systematic review.
Good morning. Good morning, my name is Jima. I'm from Prince Wales Community Consultancy. An innovative qualitative project was developed from attending COP, and with mentoring support from Sue and Scott, and with my peer support from COP participants. The experience of urinary incontinence to the eyes of older person living in the community. Urinary incontinence is a prevalent health issue affecting individuals' physical, psychological, and social well-being. And the prevalence of UI increases with age. In Australia, about 30% of older adults aged 65 experience UI. It often remains underreported and undertreated due to social stigma, embarrassment, and lack of awareness. This project focuses on improving the UI care on the older individual, voluntary population group. Poor management of UI is likely to increase the risk of falling at home, limit socialization, and reduce the quality of life. Prince Wales Community Health receives 4,000 referrals, as you can see from the slides, with active client increase 20%. Demand for UI service has increased and is likely to continue to increasing given the association between the UI and older age. Currently, 81% of Prince Wales Community Health clients are aged over 70. This project aims to address a research gap by exploring and reporting the physical, emotional, and social impact of urinary incontinence on older individuals attending Prince Wales Hospital. This is a qualitative study using Brown and Clark 6-step systematic analysis to analyze the data. The outcome of the study is aimed to inform a new model of person-centered, compassionate community care to the older individuals living with UI. And this new model of care will be evaluated in the future projects.
Thank you. So this final project I'm presenting on behalf of Will and Rui, who were unable to attend today. Will and Rui work as CNCs in spinal cord injury in acute and rehabilitation services. They acknowledge that people living with spinal cord injury are at high risk of developing pressure injuries. They also acknowledge the adjustment and challenging time that people move from being independent to... Sorry, just give me 1 second. Now, independent to dependence. The long-handed mirror was implemented 12 months ago with the goal to decrease the risk of pressure injury and to empower people to be able to self-assess their skin. This study aims to evaluate and explore the persons living with spinal cord injury experience using the long-handed mirror to assess their skin, to also look at the enablers and the barriers of using the long-handed mirror, and finally to be able to have to explore the willingness of people living with spinal cord injury to be involved in a co-designed project where they are the persons or the experts with lived experience and that it will address their care needs. So, in conclusion, thank you, that's a bit better. We believe the pilot nursing research, and this is a pilot, it's a small one, just to kind of explore the landscapes to how it would work. It has built the research capacity and capability of registered nurses. It has extended the capacity of our postdoctoral nurses to be engaged in research and also work with academic nurses. Those who attend to develop nursing knowledge, skills, understanding of research processes, health data, ethical considerations and the principles of co-designing research going forward, and envisage that this cohort will actually be our research champions moving forward and will impart their knowledge to others who are less experienced. All of these projects are on time and we believe that they will be completed by the end of this year. Finally, I'd like to acknowledge Karen Tequili and Natalie Muir, who are the dons who have supported this project, the nurse co-directors who allowed the CNCs to leave their practice to be able to attend the research workshops and mentoring mentee appointments, the UTS Nurse Midwifery and Public Health academic staff who contributed to the establishing, and finally just to note that this project was funded by Strategy Reserve funding, a small amount which provided some resources. And one other thing was the Prince of Wales Foundation funded the last project that I presented, which was for the spinal cord injury patients. Thank you.
Thank you very much, Sue, and appreciate the patience with the tech issues in there too. But thank you also to Renier, Daphne, and Jinwa. In the spirit of time, we're running slightly over. We've got one other speaker before morning tea. So unless there's an urgent question, and that's not an incontinence or a continence pun, but if can I maybe reserve any urgent questions for the morning tea, if that's okay. But to say thank you to our panel of speakers from Prince of Wales. Okay, so thank you. And our last speaker before morning tea, we have Shifa Azjaril, who is a CNC for wound and skin integrity at the Sutherland Hospital. Shifa will be presenting on the application of improvement science to alleviate pressure injuries, a critical aspect of patient care. Her innovative approach and expertise in wound care will provide us with valuable strategies to enhance patient outcomes. So please welcome Shifa.
Thank you. What a hard act to follow. Great presenters. So thanks for having me. I know it's before morning tea, so a hard slot, but I'll try and be timely. So before I begin, I'd like to acknowledge all the obviously on Visual and Lambian today, and also I wouldn't be here today without all of the hard work of my team. So I won't read them all out, but I know who they are, and if they're online or in the room, thanks for your ongoing support. So this project was over 2 years. Sorry, beg your pardon. Let me just back it up a bit. Alignment and strategy. So our alignment, as you can see there, was over 6. So I'll go through and you can see each strategy will pop up as I carry on. So I won't read them out, but I'll show you there. So I'm just going to make it a little bit interesting. So if you've got arthritis, you've got an injury, you don't have to do it. If you could sit on your fingers for me while I speak on this slide. So why is it important? Okay, so pressure. So pressure injury reduces the quality of life of our patients. It causes pain, discomfort, and in some cases permanent damage. It's also kind of had an ageist sort of wrap, being that it's in the older population. But it does affect the older population, but it also, the population that's got multi-morbidity, who are most at risk. Happy is hospital-acquired pressure injuries, so if I say happy, that's hospital-acquired pressure injuries. It's often preventable. So if I get you just to take your fingers off your bottoms, what are you feeling there? A bit of pain, a bit of discomfort, a bit of numbness. You've just been exposed to pressure in the last 7 seconds. So think of our patient in the ED bed, that's only 5 seconds, or anywhere sitting in the hospital, around our community, around our district, how they get exposed to pressure. It is preventable. So it's a burden on the patients. It's also because of that permanent damage that it can occur, but also on the health system. If it's preventable, it can also, a study that was conducted estimated that one hospital-acquired pressure injury costs $151,000 per patient. Then I'll talk about length of stay and the damage it has on the patient. Okay, so this is a busy slide. So in 2022, TSH Sutherland, so those of you who don't know, we're in the Sutherland Shire, our cohort of patients is 75% of our patients are the age of 65 and above. And I did say it often is sort of ages, but it affects the older population, but everyone else as well, peds, younger adults. So TSH experienced an extraordinary rise in pressure injuries. As you can see there, red, across the state compared to the district. Wow, that is not good. So in July, 24.09. Our aim, our target is 6.6. 24.09. So our peak was in July. And for those of you who don't know what a hack is, it's a hospital-acquired complication. That means stage 3, stage 4, suspected deep tissue injury or unstable. So not just a bit of redness, not a bit of skin tear, above that, okay? So back there, permanent damage, okay? So really, really bad. Okay, what did we want to do? My aim as the wound care CNC of Sutherland, I needed to do something about it. This was not good. So our aim as an organisation, we wanted to, by December 2024, it was a big aim, but we wanted to reduce the severity. So the severity of pressure injuries, so by 50% in all inpatient adult wards. And then just, I mentioned earlier about the operational definition, which means stage 3, stage 4, and stage 4 suspected deep tissue injury. Okay, so how did we do it? The method was we gathered a team, and I think the theme along today, alongside research and innovation, is that you can't do it alone. You need a team. You need support from the dons, from the patients, from the educators, from the influencers. You need a whole team. So we established a working group, and that was in April 2023. It was a multidisciplinary membership. So we had our Director of Nursing and Midwifery, we had our Clinical Governance Unit, we had CNCs, dietitians, physios, everyone was at the table. And instead of doing a blanket approach, as we historically did as an organisation, as a district, that we thought, yes, we just need to do Waterloos, we just need to do skin sections, we just need to move our patients. Yes, but that's not it. That's not all we need to do. We actually looked at the data and we looked at the in-scope areas. So what were the areas that were having trouble? Where were the areas that were having these incidents occur? So we were in scope. We chose 4 of the wards, and the leaders were either nurse unit managers, CNCs or CEDs. They were our key drivers to be at the table. And then we used baseline data to present our key findings. So we wanted, as I sort of showed you earlier, we met every 2 weeks and we shared the key learnings of what the data means. And what did we do? So we used improvement science strategies. We did coaching, and I think another important factor is to mention psychological safety. And research was mentioned, leaving our badges or our titles at the door. Yes, it was multidisciplinary, but we came to those meetings as people, as clinicians, as people to care, and that really wanted to make a difference. So we left our titles at the door, and also it was a collaboration. And it was really imperative to create psychological safety in those meetings. So I wasn't the moon CNC of the expert content, I was the person that wanted to change so was everyone else in that group. So that was really imperative in our group. We did improvement science strategies. Oh, sorry, I can go on. You'll see there, coaching, focus groups, staff surveys, drive diagrams, but I'll go on more in depth. So what does improvement science mean? So you may or may not know, we wanted a SMART goal. We wanted to be achievable, measurable, we wanted targets, we wanted it timely, and we wanted to have a vision. Process mapping was a great tool to use for this, for our people, for our team, was to really, and 5 whys, really asking the question, not because, oh, someone didn't look at the skin or they just didn't turn a patient. That's a really surface level sort of reaction to harm. It's the why. And also looking at each individual ward. What were the teams doing? What was their culture behind harm? Did they feel safe to speak up for safety? Every ward is different, every person delivering care is different, every cohort of patients in each ward is different. Thank you, sorry. Change ideas. Change ideas was really, really important, and it had to come from the wards individually. They had to decide what did their team need to create ways of working to deliver safe care in preventing pressure. So in those monthly, we shared monthly data, and we really took away the culture about the negative connotation of harm. We really learnt from those incidents, and we really looked at it together and saying, how can we make this better? And what happened was, whether it was through process mapping, whether it was through focus groups, through their team, or whether it was using appreciative inquiry in patient stories. Okay, I won't go through all the change ideas, but they're there, and you can talk to me about it later, but these are the key change ideas that occurred throughout the 2 years of the different wards. The main ones were sort of, accurate weights, and you may or may not know, or under the water load, people weren't weighing people appropriately. And if you don't know, a weight actually affects 110 power forms in our EMR system. So malnutrition, if we don't do it properly, can be lost, and we can't find. So dietetics, appropriate dietetics referrals weren't occurring. Just for time, I'm just going to carry on. So, and I think the big one there was heels at handover. So we did an example of improvement science, and the PDSA cycle was the change idea was, oh, well, I can't do a skin inspection. Why don't we do a skin inspection during handover time? When I've got double the staff, 130, there's 4 of us, it's not just the 2 of us, I can do a whole skin inspection with my section of patients. They actually tested it. So this is the beauty of improvement science. What you think is going to happen, and they did test it, and it took them 1 hour and 20 minutes to do the whole round of skin inspections with 4 people. So what they found was that's taking too much time. They're saying, let's be opportunistic and do it when we're doing a shower. It may sound simple, it may sound really, but those are the key changes to really, the key drivers are the clinicians on the floor that are doing the work. And what they found was this brilliant idea of heels and handover. It's less, because their data showed that it was heels that were sort of getting suspected deep tissue injuries and unstageables. So instead of doing a comprehensive skin inspection at handover, they did heels. Obviously, they still did this comprehensive skin inspection. However, they focused on heels over handover. I love this slide because it runs through, as I mentioned before, you can't have a size fits all with patients, with people, with staff. Things happen, things change, like COVID. As Brendan was mentioning, we are evolving. We are evolving in technology, we're evolving in, the role as a nurse itself has grown, and we're doing so much in our portfolios that we need to move with the times. And Insanity is doing the same thing over and over again. Improvement science has that brilliance, is because you move with the times, you move with the environment, you move with what's happening with the people, what's working well, what could we do better, what are the processes that are breaking down, how do we change it? So really going to the core of the problem. And I wanted to share a appreciative inquiry story that we have from a patient who was really compelling. We did interviews sort of during and after, and what came out was the communication and pressure, and the communication about her pressure injury. And also she was afraid to be turned. And they love it. I hate the word non-compliant. or, refuses, skin intact, refuses, and it carries on. But this actual story is, she felt so heard because she loves John Farnham, and she was terrified of being turned. And the nurses actually put John Farnham on and released her anxiety about being turned and gave her the education of why it was so important. So I think that's really compelling. And not one size fits all of, turning a patient every 2 hours or 4 hours or just doing a skin session. It needs to be individualised. It needs to be individualised in your teams also, and really up the culture about safety, about learning from those incidents rather than having a negative connotation around it. And I just wanted to point out that from that study that I mentioned before, length of stay, we have saved a potential of 120 days of a patient being in a bed because we reduced the severity of harm. That's amazing. And then, this is just a busy slide, but just going on the harm or the harmful twos, we actually went above the 50% in that 2-year period. So, and we are sort of performing well and truly. We're at a 0. Our aim was 0.06, I believe, from the benchmarking of our cohort. Sorry, but we're down. And then just one more slide is that we updated the policy, the continuous governance. So team, I think that's the theme it is here, getting a team, getting people supportive. We do quality showcases every 4 times a year to embed the practice, and it keeps evolving. It doesn't just stop here. And also, it's an open door policy for all the alumni that are involved, so people can drop in, have a safe space. And just that key point is a positive framework with hacks. Not being like, you've got a harm score too, really talking about it with your colleagues on the floor, in the boardroom, the DOMs out there, really talking about harm in a way that we can flip it. I think that's the big message.
That's great. Thank you, Shifa. And I think it's a very appropriate wrap up there when we're talking about person-centred care that you bring in John Farnham and the voice, so about giving a voice to all of our patients and our staff. But we might reserve questions as well for the break time if that's okay. Thank you, Shifa. So Dan had prepared a very long speech for me to go through all of the acknowledgements from the first session, but I will sacrifice that. But just suffice to say that we have had a very good representation here in the room this morning, a mixture of doves, olives, doves, owls, peacocks and eagles, and we have had fledgling researchers and those with more runs on the board. But bringing it all together there, Brendan, how every run starts with a research first step. So let's be inspired as we continue to morning tea and for the rest of the forum. So I'll hand you back to Dan. Thank you very much.
Thanks very much, Jane. And another round of applause for Jane, our session 1. We're going into morning tea. Like any good forum, we are running a little bit behind time, so we will come back into the room at 25 to 12. When we are seated again, we will kick off with our online participants again. So if we could just move back into the space. Poster voting is well and truly open, so get out there and vote away. And we'll see you all back in the room at 25 to 12. Just before you run off, we do want to say and acknowledge Brendan for his presentation this morning, and we have a small gift for you. We know you're running off to Adelaide after here, so just a little thank you from us. Hopefully it gives them a lot. Thanks so much. Enjoy morning tea. Good morning and welcome back to this morning's forum. Thank you everyone for the energy at morning tea, and I hope you got around to do your poster voting. The 2 screens near the entryway are a little bit congested, so we're going to look at moving those around, and then we might see if we can display them here at lunch, so everyone can come in and see them on the big screen. We'll see how we go with that. So welcome back, and hope you had something to eat. We've got the next session jam-packed, full of exciting presentations, and to lead us through session 2, I'd like to welcome Robin Gasparotto, who is our Director of Nursing and Midwifery for the Royal Hospital for Women. Please join me in welcoming Robin.
Thanks everyone. As Dan said, I'm Robin. I've decided to put the person behind the microphone and introduce myself as I'm a daughter, I'm a wife, and I'm a mother of 3 beautiful daughters. And I am now going to undertake, I think, the second PDSA cycle of chairing. And so let's see, on the quality improvement, I'll just remind you, we may not always get some improvement from the PDSA cycle, but I'll do my best. Thanks, Jane. So it's my pleasure to introduce our first speakers for session 2. And we have Glenn Paul, who is a cardiology clinical nurse consultant at St George Hospital, and Megan Higgs, strategy and support manager for the Division of Medicine and Cancer at St George Hospital. Both will be presenting on insight through analysis, end-to-end patient journeys. Their presentation will provide valuable insights into the comprehensive analysis of patient journeys and its impact on improving patient care. Please join me in welcoming Glenn and Megan.
Thank you very much. Megan's here in spirit. Megan couldn't make it, unfortunately. I take it that's a I'll be presenting on behalf of Megan and myself, and this was redone under the guidance and support of Brendan Matthews, the Director of Medicine and Cancer. So insight through analysis, cardiology, end-to-end patient journeys. I'd like to acknowledge country. The alignment strategy is creating a supportive environment and delivering high-quality, safe, person-centred care. And I suppose a lot of the work, and I've got another presentation a bit later, really aligns a lot to what Brendan was talking about, and some of the other speakers have been talking about as well. So the background to this presentation is really it's refreshing. This is research and innovation, because certainly the innovation part is critically important, and this is really evidence-based clinical practice which we're trying to implement. So the background is really patients with a cardiac condition often experience long waits and extended length of stay in the emergency departments and inpatient settings, and key challenges for that include bed availability and cardiac monitoring capacity. St George has about 150 admissions to cardiology each month, and about 1,800 to 2,000 admissions per year. So we wanted to map the patient journeys of 6 key cardiology presentations to identify the critical points that can improve that patient flow and reduce hospital length of stay. There was a pattern over the previous 3 to 4 years where we've had an extended length of stay in the emergency department, which prompted this review. So our method was we chose the top 6 cardiology DRGs in terms of separations and length of stay. Approximately 60 patient records were reviewed, and that was there to capture the patient journeys, and that was for non-ST elevation myocardial infarction, intermediate risk, acute coronary syndrome, insertion of permanent pacemaker, admission with CCF, admission with atrial fibrillation, and admission with suspected cardiac syncope. And this would represent the vast majority of those 1,800 to 2,000 cardiology inpatient admissions through a year. I do apologise for the slide. It is very busy, but I just wanted to give you a bit of an idea. Got a pointer? A bit of an idea about how we mapped things out. So across the top, we've got in the grey, we've got the letters A, B, C, D. They were the points in the patient journey, and then it went from the start of admission through the emergency department to discharge, and there were the key decision-making points during triangles. So that was just after B. So in terms of the patient presenting with acute coronary syndrome, they get triaged, they go through the emergency department. There's key diagnostic tests which are all time dependent. So serial ECGs, discuss with cardiology, possible bedside transthoracic echo, possible consent for coronary angiogram, and Newborn mouth for coronary angiogram, progressing through to waiting for a cardiac monitor bed, and the very junction through to the discharge, depending on if they had an angiogram, if they needed a PCI, if they needed cardiothoracic surgery, etc. So all that was mapped out. The entire patient journey was mapped out for non-ST septic elevation, myocardial infarction. I suppose critically, these were the key junction points which were identified, and that was, as I said, according to the letters AB, the stage the patient journey. So, as an example, so the time to transfer from ED to a cardiology monitor bed, that was on some of those influencing factors was the availability of the monitor bed, time to arrival to coronary angiogram, that was the availability of the cath lab, how we prioritise those patients in the cath lab, how the cath lab operates, what's the efficiency of the cath lab, time from angiogram to discharge home, we looked at the cardiac monitoring. So we were able to really map out the entire patient journey and what are the influencing factors which potentially we can then target for intervention. So we did this for non-STEMI. We did the same process for intermediate risk acute coronary syndrome, which is a major challenge for us in the emergency department, deciding if they stay, if they go. We did it for insertion of permanent pacemaker, where we often have prolonged length of stay with people waiting on a permanent pacemaker, and some of the key junction points which we can target for that. Congestive cardiac failure, once again, very complex disease process. Lots of processes which have the potential to delay and extend our length of stay, which are currently about 8 to 9 days for F62A, which is heart failure with complications. We did it for atrial fibrillation, the most common arrhythmia we see in the emergency department. Often there's opportunities to contract that length of stay, and also another common presentation was suspected cardiac syncope. All of these we had the key influencing factors and to inform us about where we might be able to target some interventions. So from the results, we're looking at all that data and actually knowing our business, knowing what we're going to be doing, knowing what the patient journeys are. We looked at the time to review by a senior cardiology decision maker was really critical and can really delay that patient journey significantly. Not only time to review an ED, but also time to review when they're on the wards. Availability of monitored beds, that's something which is sort of in our control, which I'll talk about later. The duration of cardiac monitoring, inpatient access to procedures in the cath lab. It's not unusual for us to go a week with the patient waiting in bed, just waiting for access. Opportunities once again for improvement, and access to functional tests like CTCA and stress echoes and exercise stress test. The opportunities to improve flow and average length of stay basis on these findings were early ED rounding by a senior cardiology decision maker, not the VPT, because they're not the decision maker. Clear documentation of cardiac monitoring, so if someone comes in at 6 p.m. and they're for 24 hours cardiac monitoring, that doesn't start at 8 a.m. the next morning when cardiologists see them. Alignment with the cardiology monitoring guidelines, which is put out through ACI New South Wales Health. Prioritisation of inpatients to get them out so they get through to the cath lab. Prioritisation of pacemaker procedures, establishing a chest pain clinic, and dedicating time slots for those diagnostic tests. So we wanted to reduce delays in high priority decision making, improve access to the management of cardiac monitored beds, enhancing patient access to cardiac catheter lab, and improve our, it's called ETP anymore, it's called something else, but anyway, ETP to reduce length of stay in the emergency department. So, in conclusion, I think this was actually not solid. In conclusion, so mapping of these end-to-end patient journeys with the support of a strategy manager, with Megan provided valuable insights into critical areas for improving patient flow and reducing hospital length of stay. But addressing these challenges requires improvement in operational processes, resource allocation, and interdepartmental collaboration to enhance patient care and overall service delivery. What it's also really useful for is orientating our staff to the process, to the patient journey. So when the new BPT starts, we can say, this is how it works, this is what happens for atrial fibrillation, this is what happens for non-STEMI, this is what happens for a pacemaker. So there's this visual orientation for not only our medical staff, but also our nursing staff. So this would be emailed to each of the ceremonies when they first start. For strategic planning and for service review. So, thank you very much.
Thanks, Glenn. It was an insightful presentation. Do we have any questions from the audience? One at the back.
Thanks for that, Glenn. My name's Janine Bodie. I'm from St George Hospital, CNC Surgery. Glenn, I was wondering whether you picked your top DRGs to look at the patient journeys, with the patient journeys in that. Do you think there'd be any value in mapping other cohorts within cardiology?
Yeah, thanks. Yes, we chose the top DRGs because they're the ones that hurt us most in terms of our length of stay and separations. There's opportunities to contract that length of stay. But within those patient journeys, there's other journeys, like specifically the delays with the cath lab. So mapping what's happening with the cath lab would also be extremely useful. What time do you start? When do the cardiologists come? Is it running from 8:30 to 4:30? So I think actually mapping how those dependent services work would also offer insights to maybe optimise their performance, which would then once again come back and help those other aspects of the patient journey, given so much is dependent on those interventions. Some of the other benefits which we've done, so we've now got a chest pain clinic, we've got a cardiac monitoring, our clinical business rule, the duration of the cardiac monitoring. So there's been some real progress as a result of these patient journeys, but I would say that we can look through them at any time and say, okay, let's pick this one, let's pick this one, let's pick this one, and visually it makes sense. It's good design. People can see where we can have the most impact.
There's another question.
Hi, Glenn. Great presentation. Do you have any data on your length of stay now that you've put these in place?
The length of stay, we have our usual length of stay data. We try to get normally annually. We're trying to maybe get access to the regular health table data. I think that critically we need strategic planning. So actually we need to all sit down and as like a group, and I think that that's something which I think is a real opportunity to sort of use these patient journeys, but then use the data then to actually prioritise which area of those patient journeys do we need to target and find out more about it, put forward some interventions which will be informed by the patient journeys, and then we can measure that. But our patient lengths of stay stays pretty much the same, but we haven't really looked individually at that. I'll be more interested in time delays, which is associated with length of stay. Yeah.
Thank you, Glenn. Thanks for sharing with us your data-driven insights. is Jude Tias, who is a registered nurse at St George Hospital. Jude is discussing enhancing patient safety, leveraging COVID-19 lessons to reduce hospital-acquired infections. This presentation will highlight the critical lessons learned during the COVID-19 pandemic and how they can be applied to reduce hospital-acquired infections and, of course, enhance patient safety. Welcome, Jude.
Good morning. Yes, good morning. So, good morning, and thank you, Robin. My name is Jude, and I'm a registered nurse working here at the Centre for Research and in ICU at St George. So today I'll be presenting a project about lessons learned from COVID-19 to reduce hospital-acquired infections, or HAIs, on behalf of my team of co-authors. This comes from a published paper, which was a systematic review and meta-analysis about this topic. And it was published with the Journal of Hospital Infection in February 2024. And also think it's good timing with this, as yesterday was World Hand Hygiene Day. So I'd like to acknowledge the Aboriginal and Torres Strait Islander peoples of the Darrawal, Gadigal, Wangal people and Bidjigal peoples. So the category for this presentation is delivering high quality, safe person-centered care, and strategy is to create the conditions to utilize evidence to assist in developing and delivering person-centered, high-quality, safe care. This review supports the delivery of high-quality, safe person-centered care by using evidence to evaluate the impact of PPE on hospital-acquired infections during COVID-19. It aligns with the strategic actions by informing infection control strategies to improve safety and outcomes. So a bit of background, looking back, COVID-19 pandemic dramatically reshaped the landscape of healthcare both locally and globally. The pandemic highlighted the key importance of infection control measures within the healthcare settings, and among the main concerns that emerged were HAIs, hospital-acquired infections. So these arose as a substantial threat, posing considerable risks to patients, healthcare workers, and the overall healthcare infrastructure. In response to the pandemic, healthcare organisations and professionals implemented a range of infection prevention and control measures, including the widespread deployment of PPE, or personal protective equipment. And as you may recall, there were lots of different PPE types, from gowns and N95s to the full bodysuits that we saw overseas. Specifically here in the ICU, they introduced a set of PPE and using them for prolonged hours. And the idea was to reduce the number of times that staff changed PPE and therefore less exposed to COVID. And so I wondered, how would this affect the HAIs in the hospital? And so the aims of this systematic review was to comprehensively synthesize and conduct a meta-analysis based on the best available evidence regarding the prevalence of HAIs unrelated to COVID, and we employed a before and after approach between 2019 to 2021. The findings of this systematic review can be used to guide policymakers, healthcare administrators, and infection prevention teams in developing evidence-based strategies to minimize HAIs and optimize patient safety in both pandemic and non-pandemic settings. So in terms of the search strategy, the study was conducted in accordance with PRISMA and JBI methodology for systematic reviews. A protocol was registered for the systematic review of Prospero, and a preliminary search was done on Medline to conduct determine the index and mesh terms, and then a full search strategy was then developed with databases CINAHL, Medline, Embase, and SciInfo being used. We also use Google Scholar to source unpublished studies, and we use keywords related to COVID, PPE, and MRO. It was limited to studies in English and published between 2020 and July 2023. And all studies were identified during the search were imported into EndNote. Screening was done for title and abstracts as well. In regard to the selection criteria, so manuscripts that we included were ones that had incidents of HAI comparisons, respiratory infections, multis, eclampsies, and wound infections, as well as ventilator infections. they were excluded. There were no age ranges, no infection control strategies, and it was not during COVID-19 periods. And then studies were then appraised using the 8-item JBI critical appraisal tool by 4 independent reviewers. In terms of the studies, so the search resulted in 981 publications, and then following the removal of 233 duplicates, we had 748 studies that were identified for screening. After subsequent screening of titles and abstracts, 182 studies were selected for full test review, and out of these, 15 studies were included in the final review and analysis. We had an Excel spreadsheet that we used for extraction, including data for demographics, tests that were used, different HAIs that were identified, time frame, and then the overall results. We did the data for the included studies and pulled them into statistical meta-analyses using RevView Manager or RevMan. And then the effect sizes are stated as risk ratios for dichotomous data, and 95% confidence intervals were calculated. And then statistical heterogeneity was assessed in the meta-analysis using I-squared and chi-squared statistics. In terms of characteristics, we had 9 different studies with Italy and USA and Spain having the most. Of the 15 manuscripts, we had 9 different retrospective case controls, 3 incident comparisons, 1 observational study, 1 analysis, and 1 cross-sectional study. There was a large range of HAIs investigated within these studies, including CLABSIs, C. diff, and CORTIs, and there was an overwhelming number of microorganisms, which we then grouped into genus types. These included gram-positive bacteria like Staph and Enterococcus, as well as gram-negative bacteria like Klebsiella and Pseudomonas, to name a few. And then the other HAIs investigated were respiratory infections, ventilator-associated infections, and surgical site infections as well. Regarding the meta-analysis, so we grouped the main studies which had the data available into 2 subgroups and pulled the data for the meta-analysis. The 2 subgroups were ones that reported the number of cultures, and then studies that reported the number of patients. So overall, 3 studies reported their results based on the number of positive blood and urine cultures. The data from these studies demonstrated a statistically significant increase in the number of positive cultures during COVID-19 compared to the pre-COVID-19 period. So that's the top half. And then the 4 studies in the lower half report results based on the number of patients. As you can see, the pooled data from these studies showed a non-significant decrease in the number of patients with positive cultures during COVID-19 period and compared to the pre-COVID-19 period, with the risk ratio of 1.29. So overall, the remaining studies were grouped and analysed based on their method of reporting the infectious and infection rates. 3 studies used the incidence rate per 10,000 bed days as a metric for evaluating the occurrence of C. diff infections. All 3 of those studies reported a reduction in incidence rates during the COVID-19 period. One of the studies demonstrated a decrease in incidence rates per 1,000 catheter days from 2019 to 2020, and then there were 5 studies that showed an increase in the COVID-19 period, with 1 showing no difference. 2 studies that reported the CORTIs showed no differences between the periods, and then the same result as well for 1 study that reported on the ventilator-acquired infections. In terms of statistically significant results, those that were not included in 2 subgroups of patients and cultures were then noted to have statistically significant changes. We had 1 study, Esposito, which was reported for catheter device-associated infections, and it showed a statistically significant decrease in incidence rates per 1,000 catheter days, from 2.6 in 2019 down to 0.9 in 2020. And then pooled data from the Rose and Perez-Miranda studies showed a significant increase in positive blood and catheter tip cultures for CLABSIs during the COVID-19 period compared to the pre-COVID-19 period. And then Rosenthal et al. Demonstrated a statistically significant increase in the incidence of CLABSIs per 1,000 bed days, from 2.54 down to 4.7, up to 4.73 during COVID-19 period. And then finally, Patel et al. Showed a significant increase in the standardized infection ratios from 0.68 in 2019 up to 0.87 in 2020. So discussion limitations. So as you've noticed, there was a vast number of HAIs that were reported on, and in the review, we found that there were mixed results. Various studies use different ways to report the microorganisms, with some reporting to genus, some reporting to species, and others to strains. So to overcome this, we decided that we would group it according to genus. The time periods were also different, so we had pre-COVID-19 and during COVID-19 that varied among the studies. The results for this review that we reported as 2018 to 2019 for the pre-COVID period, and then 2020 to 2021 for during COVID. There were also issues with stockpiles and supply chains, as well as having issues with importing PPE during COVID. Pardon me. This makes it challenging to discern whether shortages or improper PPE utilization might be responsible for the situations where an apparent increase in HAIs were observed. And then additionally, the other reported potential reasons for HAI increase during COVID-19 pandemic included high patient acuity, differing antibiotic use, staff shortages, to name a few. The analysis did not delve into this because the focus of the study was to primarily focus on how the COVID-19 period affected the incidence of HAIs, and as such it was decided that these were outside the scope of the paper. So why should we care? So implications for practice. Overall, the findings suggest a complex picture of infection rates during the COVID-19 pandemic. Given the inconsistent results, it suggests that core infection control practices such as hand hygiene, standard PPE, and staff education are paramount for ensuring hospital-acquired infections are kept to a minimum. Despite difficulties in accessing PPE, staff shortages, and confusion that comes with a rapidly changing environment, thanks to a global pandemic, these basic infection control practices ensure that rates of infection remain stable. Further research and analysis were warranted to better understand the multifaceted impacts of the pandemic on HAIs. Given the inconsistencies with the results, debug limitations should be addressed for future papers, as well as larger scale prospective studies to assess the effect of PPE and new IPC practices on HAI rates. This study was a collaboration between St. George Hospital, the University of Wollongong, and the University of Newcastle, as well as affiliations with Western Sydney and Joanna Briggs Institute. So I'd like to thank Lucinda, Heidi, Alison, and Richard, who couldn't be here today. Some references, and I'll attach the QR code at the end for anyone who wants to read the article. Thank you.
Thank you, Jude. We are very appreciative of your very clear and robust methodology and your analysis of such great data. Can I call, are there any questions within the audience or online? No? Okay, so I'll just throw to you, Jude. Could you highlight for us one particular surprise that you discovered during your research, and how did you communicate that with your colleagues, your team and leadership team?
Personally, I was surprised with how long this took me to do. When I started this project, I was completely new to research, and I was under the impression that it's just a review, it's just looking at papers. So I thought maybe that it wouldn't take as long as it did. It took me almost 12 months to complete this review. But I guess going back to what was said this morning as well, it's just research is a team effort. And so it was thanks to my team that I was able to complete this. So, yeah.
Congratulations. Please join me in congratulations. It's now my pleasure to introduce Yvonne Steadwood, who's the nurse educator at Newark Prince of Wales Hospital. Yvonne will be presenting on the Accelerate Plus trial, a significant initiative aimed at advancing nursing education and practice. Her insights into this trial will provide us with a deeper understanding of the objectives and outcomes. Let's give a warm welcome to Yvonne.
Hi everybody, thank you for inviting me today here to present Accelerate Plus. Accelerate Plus is assessment, communication and excellence for safe patient outcomes. Accelerate Plus was a stepwise cluster randomised controlled trial in collaboration with Nursing Research Institute St Vincent's, Health Network Sydney, St Vincent's Hospital Melbourne and Australian Catholic University, along with multiple contributing universities, professors and 8 hospital sites across New South Wales and Victoria. That requires nurses to conduct a systematic, comprehensive patient assessment, perform patient-centred bedside handover and escalate concerns to the multidisciplinary team. So why am I here speaking today? So just a little bit about my role. So I have been the site lead at Prince of Wales for Accelerate since 2021. I then had the amazing opportunity in secondment to go and work at Nursing Research Institute at the beginning of 2024 as a project manager for 2 months, and then as a further 6 months as project manager for Accelerate, which was the sustainability of the project and rollout. I would like to also take this moment and opportunity to personally acknowledge the leadership and support of Professor Sandy Middleton, Director of Nursing and Research Institute, Karen Takiri, Director of Nursing Prince of Wales Hospital, and the project manager for Accelerate Plus at the time, Susan Whittam. So I'd just like to acknowledge the traditional custodians of the lands in which we operate today. So strategic alignment. So our strategic alignment is delivering high quality, safe person-centred care. The nurse-led research, Accelerate Plus, empowers and supports nurses to come together to create shared understanding and unique goals to provide holistic, safer, high-quality, person-centred care. Working with individuals, teams, patients and healthcare professionals to provide best individual, person-centred care, creating an inclusive culture to support positive clinical outcomes that are essential in supporting improvements and innovation. So the background that we know. The nurses have a critical role in preventing harm through proactive assessment and communication of clinical findings to the multidisciplinary team. Poor patient outcomes occur from delayed detection and response to inpatient deterioration, falls and pressure injuries. There is a need to move away from the medical rescue model to early identification of problems. Comprehensive assessment with prompt multidisciplinary communication of the clinical assessment findings has potential to address these harms. So this is the proposed model of a nurse proactive assessment and communication model. Up to 80% of serious adverse events are preceded by clinical signs of instability 24 hours or more before the event. The proxy for a traditional comprehensive assessment has become a greater reliance on vital signs and technology to detect deterioration of patients' condition. In this project, we hypothesise that if all nurses complete an evidence-based assessment for all allocated patients at the start of the shift, so in this graph you can see it's the beginning of the shift, not waiting for your routine vital observations, and communicate effectively with the multidisciplinary team, nurses can recognise, respond and put mitigating strategies in place before the patient needs the rescue team response. So the aim of Accelerate Plus was to implement and evaluate the effectiveness on patient, clinical and economic outcomes of a remotely facilitated organisational ward-level intervention to improve comprehensive, systematic patient assessment by nurses and to improve clinical handover. As I said before, the design was a stepwise cluster randomised controlled trial, which had pre-test and post-test surveys of nurses, doctors and patients. There were settings of three wards in each site, so the sites were St Vincent's Sydney, Prince of Wales Sydney, St Vincent's Melbourne, Lismore Base Hospital, the Sutherland Hospital, St George Hospital, Royal Prince Alfred Hospital and Fairfield Hospital. So to ensure this was embedded, and we actually facilitated a cascading facilitation model, what we found was that additional roles and involvement was required and that different stakeholder groups played different roles. We call this a cascading facilitation model, where a flow of information and change management was required from one level to the next. Our model for facilitation, interlab and partnerships and support wrapped around each level. At the centre, the reason we're here for is our patients. So you can see there's our patients on this level, and then outside is our bedside nurses who we do the education with, and we have a multidisciplinary team approach and champions. Then we have the nurse unit managers working with site leads. And then we have the executive support of hospitals and local health districts. And then overaction, we have our academic partners and researchers. So what did the intervention look like? So the intervention, the clinical structure was, as I said, an A to E physical comprehensive assessment at the start of each shift by the nurses. Nurse participation in multidisciplinary ward rounds to communicate assessment findings, and a structured centred bedside handover using ISVAR. And something which was slightly different was CARE, so that was actually introduced by Australian National University, and it was to do with the handover process and how we engage with our patients. So that is actually how we engage with them, so that's how we actually connect, ask, respond and empathise. Okay, so our implementation strategies, so what did they look like? So the implementation strategies were non-leadership workshops, which were full days, nurse workshops and barriers to identify what the challenges might be in each unit. These nurse workshops were ran for about 3 hours, which increased nurse engagement, gave the nurses a voice at that point in time, got them to look at their own workflow and what their challenges might be in their unit, how they would like to do things differently. And collated in those workshops, we took that back and worked on an action plan with the leadership team. So that was a co-design action plans, and then the recommendations. Multidisciplinary support meetings, so there was also support meetings with the heads of departments, with the doctors at local level, and NUMS engaging with the direct doctors that were in their own units. And then we have the overaction in nurse and executive support. So that actually, at Prince of Wales for us, was the monthly action plan meetings with the NUMS as they came on site, and with the co-directors and the director of nursing. And so any kind of challenge you'd have at that point that they couldn't fix or overcome board level was escalated to executive support, which was really great. And the nurses also on the floor had that chance to actually use their voice and continually make suggestions to the nurse unit manager and what their challenges were. And then there was also additional resources and posters and written materials, and then the support of the clinical, as the clinical leads at that point, I'm just going to put this up just to share this. This is actually the outcomes that we had. So the primary outcomes were composite measures of met calls, unplanned ICU admissions, inpatient falls and pressure injuries. So this sample was collected at all sites pre and post. And then our secondary test results were surveys of nurses and doctors and patients. So they were looking at perceptions of organisational readiness to change, barriers to physical assessment and staff engagement. And nurses interpretation, collaboration, scale and safety culture, and the patient experience of safety measures, health status and friends and family tests. There was also a process evaluation done at the end, which involved across all the sites a snapshot of each category of living nurses, sites, NUMS and director of nursing. And there was a cost-effective compared analysis as well at the end. I'm only sharing the challenges because what the research team and Professor